Good morning, everybody, and welcome to the National Kidney Federation's annual conference. This is the first time we've held it virtually, and hopefully next year we will be back to a usual format of being able to meet each other in person. The last 18 months has obviously been extremely difficult for kidney patients, their families and their carers. Let's hope things can now start to improve for everybody. Today we have 8 speakers: our own Chief Executive, Andrea Brown, Lisa Burnham, Professor Jeremy Hughes, Catherine Parker, James Gilbert, Stephen Higgins, Andy Cole and Nicola Ward. They are an engaging mixture of patients and professionals. The NKF is extremely saddened by the death of many friends over the past 2 years since we last met. Let us not forget all our friends who have died since our last meeting. All have worked tirelessly for the NKF and improvements in kidney care, and they all will be very sadly missed. May I ask you now to take 1 minute's silence in their memory. Thank you. Thank you all. Just a reminder that the NKF Council meeting will take place at 2:10 p.m. And the Zoom link for the meeting has been sent to everybody who has registered. Thank you very much. I will now hand you over to Pete, who I'm sure you all know as our fundraising and marketing manager. Peter.
Thank you, Jim. Well, welcome to the 40th patient event. I'm going to be with you for the next 4 hours on and off, introducing the speakers. We're also going to be taking your questions. Now, if you want to ask a question to one of the speakers, all you need to do is write in the right-hand side box your question, and I'm going to select a few. So the first speaker is Andrea Brown, our Chief Executive. Now, Andrea's been with the charity for 9 years, and in this time worked in the helpline, been the office manager, and now Chief Executive. And as you're going to hear, the charity is in an excellent position, helping more patients than ever before.
Good morning, everyone. Thank you for joining us today for the virtual patients event. This is the first time we have held the event in this format, and it will hopefully be the last. We know how much everyone enjoys the face-to-face events, as it gives us time to speak with old and new friends. We enjoy chatting in the exhibition rooms, over lunch and in the corridors. The social interaction is what we all miss. So we hope we can see you all next year in the flesh. Here is a brief outline of some of the work the NKF has been doing this year. So the first thing I need to start talking about is something we never knew about 2 years ago, COVID-19. This horrible disease came bursting into all of our lives and completely changed the way of the world, the way we live, the way we greet people, the way we interact in our daily lives. It really has impacted us all. Our patients have had the most horrendous time over the last 18 months. They have not been given timely advice from the NHS. GP's appointments have become non-existent face-to-face. And well, if you need a dentist, you may as well say goodbye to your teeth. We've gone in and out of lockdowns, have shielded, paused shielding and ended shielding. We have had first vaccines, second vaccines, and have gone through uncertainties of third vaccine doses and boosters. Are we eligible? When will we have one? Is the end in sight? I don't think so. It's here to stay for now. At the start of the pandemic, we joined the COVID-19 Renal Guidance Group, which was headed by the Renal Association, now known as the UK Kidney Association, and chaired by Paul Cockwell. This was a very large group of renal professionals and kidney charities working together to make lives for patients as good as possible during the pandemic. This group had subgroups, which the NKF was involved in, one being KQIP, ensuring hemodialysis patient safety, chaired by Rosie Don. This group provided information, guidance, and joint statements for renal professionals and patients. We have provided lots of up-to-date information on our website throughout the pandemic, and have also signposted from there to other useful resources to support patients. At the start of the pandemic, the helpline received hundreds of calls weekly from very worried patients and carers, and they have guided and advised them through the pandemic. We designed, produced and sold 17,000 social distancing lanyards and 6,000 face masks to help patients feel safe when they are out and about. We are still selling both. There has been another high demand for the NKF face masks, as many are saying they are the most comfortable masks they have worn. During 2020, the NKF asked stakeholders and KPAs to do an analysis of the NKF and feedback what we could put into our new 5-year strategy. The executive committee and staff got together to devise and produce a 5-year strategy. The strategy is ambitious, but this is what will guide the charity through the next 5 years to ensure it is meeting the needs of our kidney community. The vision is a better future for those affected by kidney disease and their families. The mission is to improve the quality of life of kidney patients and their families across the UK. And the values are: together we are stronger, responsive, supportive and inclusive. From the strategy, we produced a development plan for 2021 and we will update this yearly. The development plan has input from the executive committee and the full staff team, setting the priorities for the year ahead. The plan is monitored regularly by the staff team and the executive committee, ensuring we meet targets. We produced, published and sent out our very first impact report, updating everyone on what had been achieved by the NKF in 2020. Impact reports will now be produced yearly. It is important that we update our stakeholders and supporters with what we have achieved. We have increased our staff team now and have a team of 9. We will have 11 when our 2 vacancies are filled. This is the most staff the NKF has had in years. This year we have been lucky to have had more executive committee members join our board than what we have had in previous years. The time and dedication they give to the charity as volunteers is to be commended, and I thank them for their help and support. We have strengthened our networks considerably in the last year. At the beginning of the year, we renamed and redesigned our patient information leaflets, now called Kidney Issues, and sent samples of them along with a newly designed patient support pack to over 300 renal units and to all KPAs. They have been well received and lots of orders have been received, printed, packed and posted. During the pandemic, KPAs were struggling to hold meetings due to not being able to meet face to face. We enabled them to hold meetings using our Zoom account, and it is now used by many KPAs to facilitate their meetings. We also identified KPA ambassadors. Ambassadors are there to provide help and information to other KPAs who may require a little help and support. We are about to get this off the ground. NKF was invited to join the Renal Services Transformation Programme by NHS England, known as RSTP. We have different NKF reps on all of the 5 work streams, which are dialysis, transplantation, acute kidney injury, systems working and chronic kidney disease. I am the NKF rep for the RSTP programme board. The aim of the programme is to support the transformation of renal services through commissioning to improve the quality of care and outcomes for patients, in particular to support renal services in their recovery of elective activity following the pandemic, and to benefit from more integrated commission of services within local systems. NKF will ensure the patient voice is heard throughout the life of this programme. The all-party parliamentary group has now all of its officers and is awaiting its AGM. The group will hold regular meetings to highlight the most relevant renal issues. We will continue our collaborative work with the UK Kidney Association, NHS England, NHS Blood and Transplant, and the other kidney charities. We have collaborated with Kidney Research UK to help fund a COVID-19 vaccine research study for hemodialysis patients, along with several KPAs. Researchers from Imperial College London and the Francis Crick Institute are investigating how well the COVID-19 vaccines provide immunity to COVID-19 infection. Blood samples from more than 1,200 hemodialysis patients across the UK are being studied before and after each dose of vaccine. Data from the first 180 patients was accepted for publication in The Lancet. This shows that in patients who have not been previously infected with the COVID-19 virus, those who have received the Pfizer vaccine have 6 times higher level of neutralizing antibodies against the more contagious Delta variant compared with people who received the AstraZeneca vaccine. The researchers said the level of neutralizing antibody to Delta made by hemodialysis patients who have not had prior COVID-19 infection and received the AstraZeneca vaccine might not be enough to prevent infection with Delta. Importantly, we have found that this group without prior infection responds well to mRNA vaccines such as the Pfizer vaccine, and we can use this information to inform future vaccination strategies. Knowing the way in which patients respond to different vaccines is crucial to ensuring the best outcomes are obtained for the kidney community. The evidence provided by the study is so far helping to inform scientists and clinicians with the decisions about future vaccinations. At the end of October, researchers will report on the 6-month findings of the study, highlighting any emerging trends. The NKF is also working closer with renal paediatric services and professionals, seeing where we can provide help and support. We have increased our national profile by interacting with our community on social media networks, our website, our newsletter, and our quarterly magazine, Kidney Life. Social media followers are increasing all of the time. We currently have over 5,000 followers on Twitter. Facebook has nearly 6,000 followers, and Instagram is something we haven't been using for long, but followers are increasing. The traffic to the website has always been good. In a 9-month period, we have had 500,000 sessions, which was a large increase to previous months. Our monthly newsletter, In Touch, is emailed to over 8,000 supporters. Kidney Life, our quarterly magazine, is printed and posted out, as well as sent electronically to over 20,000 supporters. At the beginning of 2021, we launched a national campaign to increase home dialysis in the context of COVID-19. The campaign followed a webinar we hosted in September 2020, which resulted in a report with 7 recommendations. One of the recommendations was to request clinical directors of renal services to develop a plan of action to reach a minimum prevalence rate of 20% of patients receiving home dialysis by 2024. This plan is to include staffing levels, training needs, support and training for patients, a review of shared decision making, address the barriers of home dialysis faced by BAME patients, and to work with local KPAs to develop the plan. On the 1st of September this year, the NKF launched a home dialysis peer support service. We have over 20 wonderful volunteers who are fully trained to speak with people who are wanting or thinking about dialysing at home. This has gained fantastic momentum in the last month and has had some great support from patients and clinicians. This is the first national home dialysis peer support service in the UK. Please do get in touch if you require any further information on this service. Over the next couple of months, we'll be undertaking a survey of dialysis patients to find out about the barriers of home dialysis in the context of COVID-19. We are doing this in conjunction with the University of Hertfordshire and will publish the findings in the new year. We are also encouraging KPAs to raise home dialysis with their clinical directors. We will publish an updated report on the campaign in early 2022, This will include centre-by-centre data with the support of the UK Renal Registry. NKF Helpline is the most valued service for patients, carers and healthcare professionals. We have had increasing calls and we are developing the service. We have increased the staffing hours and will continue to do this to meet the needs and demand of the service. Helpline are also managing the peer support service through every stage. During the first 9 months of this year, the Helpline have helped, supported and guided over 4,500 callers. The top caller topics are COVID-19, CKD, medical advice and dialysis. The Helpline manages a huge leaflet library. They process all of the orders received by patients and renal units. All of this is done in-house, from printing to folding to packing and posting. And we are fortunate to have the help and support of Mr. Jeremy Crane, who reviews our medical leaflets to ensure they are up to date with the latest guidance. Fundraising is going from strength to strength. This year we introduced a new challenge called Best Foot Forward. This has been the challenge that has made the most impact and income for the NKF to date. We continue to do our other challenges, the Water Challenge and Choctober, both of which have lots of participants. Our marketing team work with the Kidney Charities Together Communications Group, where the kidney charities work together on joint COVID communications and yearly events such as World Kidney Day. It is great to see the charities working together to ensure the messaging to patients is uniform. We have this year introduced 3 new roles to ensure we are communicating and marketing the charity to our supporters in the best way possible. Here are some of the key things the NKF will be doing in 2022. We'll be holding patient-focused webinars. We'll be working closely with KPAs to identify any help and support they may need. We will continue to develop the National Peer Support Service with the NKF Helpline. We will provide an update on the home dialysis campaign and work with providers and clinicians to see how we can integrate this in advanced kidney care pathways. We will develop useful patient blogs and videos on our website. We will work with the Renal Services Transformation Programme to ensure the patient voice is represented at all levels and monitor the new integrated care services and the impact this has on specialised services. We will continue to work with the NHS Blood and Transplant with regard to donation, transplantation and organ utilisation. We will continue to work with our professional and patient colleagues to ensure we support patients throughout the year. I would like to thank all of our supporters, professional and patient colleagues and our industry partners for their support of the NKF. Lastly, but by no means least, I would like to thank my staff team for all of their dedication and hard work to ensure the vision, mission and values of the NKF are being met. Thank you for listening. I hope you enjoy all of the wonderful speakers we have lined up for you today.
Andrea, thank you very much. And as you can hear, what a busy charity we are at the moment. So our next speaker is Lisa Burnham, Associate Director, Living Donation and Transplanter, Nhsbt. Now, Lisa's going to be talking about the UK Living Kidney Sharing Scheme, starting in 2007. Now, as you're going to hear, is now one of the largest kidney exchange programs of its kind. Lisa.
Thank you very much, and it's a great pleasure to be with you. I think the first time I received an invitation to join you at a face-to-face meeting was probably a year ago, if not more. So it's really a great pleasure to have an opportunity actually to talk to you about this scheme, which is for some patients may be very well known, and for others actually, and indeed may have benefited from it, and for others actually may be quite hidden. So I just really want to give you an opportunity to hear about this today. So I'm just going to cover a little bit about the past, present and future of the scheme. But what I really want to do is to chat. And I want to chat with you. And of course, I can't do that because you're not in the room with me, but I know you're all out there somewhere. So during the course of this, and you don't have to do it now, but just type into the chat one thing that you'd really like to know about the kidney sharing scheme. Now, it may be that by the time I get to the end of this talk that we've covered it, but if not, and we have time, I will try and answer those questions for you. So let's go back to the beginning and where it all started. And it really started because we all know, and most of you will know, that living donation is a good thing to do for kidney patients because the outcomes are so good. And also it gives opportunity and choice for patients to have the right transplant for them at the right time. And also, of course, contributes to everybody having a transplant because the more donors we have, either living or after death, the more transplants for everybody. And economically, living donation actually really makes sense for the health economy because the longevity of these transplants means that actually more people are transplanted, fewer patients on dialysis. And not only is that better for patients, it's better for everybody. Just bear with me with the technology. I'm just, my screen is going in and out. So I don't seem to be able to move my slides on. Could you move my slide on for me, please? Thank you. So really the scheme started because up to about a third of patients donors who were willing to give to recipients who needed a transplant were unable to do so because they were incompatible either by blood group or by HLA tissue type. So other countries like the Netherlands started an exchange program, and we were interested in doing the same. I'm going to try and move my slide on, but I'm not connecting. So next slide, please. So the legal framework changed in 2006 and allowed different relationships between living donors and their recipients to exist. So for the first time, we had the opportunity for strangers to donate to people who they'd never met and for people to exchange kidneys outside traditional relationships of family or close friends. And over the years, we've continued to refine and review the scheme. Next slide, please. So in the very beginning, we just had two very basic combinations of transplants. So in April 2007, the very first matching run that we had, and we run them 4 times a year, had just 9 pairs of donors and recipients in, and we identified 1 pair. And we were absolutely delighted about this. A year later, we felt able to extend that into what we call three-way swaps, including 3 pairs in a cycle, each donor donating and each recipient receiving a transplant from the other. Next slide, please. But over the years, our ambitions for living donor transplantation were to increase the number that we did, improve outcomes for recipients, and obviously look after our donors was critically important. But actually in doing that, it was all about creating opportunities. So next slide, please. So the Living Kidney Sharing Scheme really speaks to so many of the ambitions that we had over that decade. More options for patients to have a transplant, more living donors coming into the scheme, just maximising the efficiency and number, and also importantly, making opportunities for people to have a transplant in this country and not having to move overseas for risky, high-risk transplants. And all of this has enabled us to remove some barriers to having a living donor kidney transplant. Next slide, please. So the scheme today looks like this. So every quarter, we identify not only 2-way and 3-way swaps that we introduced earlier, but now also, and if you could just press my next slide, please. You'll see that these non-directed altruistic donors, people who donate willingly and voluntarily to somebody on the list, are now introduced into this scheme to create a chain of transplants by donating to a paired recipient whose donor then donates to somebody on the waiting list. And in 2012, 2015, we had what we called short with 1 pair in the middle, and then long chains with 2 pairs in the middle. And in 2018, because of the success of these transplants, we introduced all those non-directed donors as a default into the scheme, provided that there wasn't a high priority recipient on the waiting list. And what I mean by that is that if one of these kidneys could be the golden ticket for a really long waiting patient or somebody who was really difficult to match, then that non-directed donor would donate to somebody on the waiting list. Next slide, please. So this is what it looks like if you take a graphic of that scheme, and you can see that every quarter we have between 250 and 300 pairs of donors and recipients in our matching runs, which are identified in all these different exchanges. So the technical people who developed this very clever program, produce thousands and thousands of combinations of transplants, which are then sorted out into the optimal combination of transplants for everybody. Next slide, please. So just really very quickly, all I wanted to highlight here was our matching algorithm is done by a series of criteria. The top criteria are, of course, we want to maximize the number of transplants, but we also we know that sometimes things happen to patients and they're not able to proceed. So what we do is we very carefully identify in those longer combinations an opportunity to default to a shorter combination, so as many people can still continue to be transplanted if somebody is unable to proceed. Next slide, please. So I'm not going to go through all of this in detail, but I just really want to highlight that this scheme runs across all the 4 countries in the UK. There are all sorts of very important criteria that have to be met in order for donors and recipients to go in and ensure that everybody is protected. So all the transplant assessment needs to be up to date and so on. Really importantly, if you're thinking of going into this scheme, is that you need to be aware that if for any reason your circumstances change, that has a chain reaction. And of course, those things can happen. But if you know that there are reasons that things might not work well for you, then maybe you should opt out of a matching run for that particular time. So this is a very important part to get right. It's all about the detail. Next slide, please. So it's a team sport and it requires central leadership, definitely, and that comes from NHS Blood and Transplant, and there's a whole team of us working on this. I really provide the clinical leadership and talk on behalf of my colleagues here today who really are backstage doing an awful lot of the really complicated work behind this. But actually also donors and recipients who go into this scheme have a big responsibility, a responsibility to yourselves to consider the option and to others who you're in the scheme with, so that, as I say, as many transplants as possible can proceed. And that's a difficult thing to do. It's a different way of thinking about living donation, because typically it's always been, I will give to the person I love. What this scheme enables you to do is for the person you love or the person you care about to benefit from a transplant while others do too, which to me is a win-win. Next slide, please. But we can do better. We can always do better. So what can we do? Next slide, please. So I've always called this a continuous improvement program. So from 2007, when it first started, right through to the present day, periodically, every 2 to 3 years, we have reviewed the scheme and said, what can we do better and differently to benefit patients? And our priorities have always been about making the pool bigger, because the more donors and recipients we have in the pool, the more transplants we will get out of the pool. Allowing flexibility in the scheme to enable as many transplants to happen as possible. Tackling those transplants that fall down at a late stage and really disappoint patients and cause all sorts of distress. And making sure people know about the scheme and how they can access it and who they need to talk to about it. Next slide, please. So increasing the donor pool has been about a number of things. 1 or 2 I've touched on. The first thing was increasing the number of non-directed donors that go into the pool. So as a default, as I've already said. Inclusion of compatible pairs. Now, what do I mean by that? What I mean by that is if you're a younger person and you have an older donor, so for example, a child with a grandmother who's willing to donate but not a suitable parent, that isn't an ideal age match for a child. But you could go into the scheme and get a younger donor for the child and age match the donor, the older donor, to another recipient in the pool. And this has happened, and it's absolutely joyful. About 10% of our children are now transplanted through the scheme, and about 20% of our adults. And then we talk about desensitization, which is antibody removal. And sometimes we can look at lower risk transplants for really highly sensitized patients, people with lots of antibodies. So this is a really important aspect of the scheme, that we can try and manipulate things a little bit to benefit patients who would otherwise not get a transplant opportunity at all. Next slide, please. So, and the next slide, please, because it'll bring up a box. Thank you. So donating to a stranger has become big news in the UK. Everybody was very sceptical about it in the beginning because the experience in other countries told us that people didn't do this kind of thing. Well, they do in the UK. And the Give a Kidney charity, as you know, have been huge, great proponents of this scheme. And you can see there on the right-hand side in that box that over the years, they have facilitated more than 1,000 transplants. So 847 donors at the end of March this year, and that's increased since, have facilitated 1,177 transplants. So that's really huge. And when they go into a chain, then actually the benefit is increased. So this is a really important part of what we do. They are the game changers, and this is where the magic happens. Next slide, please. Now, I talked about inclusion of compatible pairs, and if you could just give me my next slide, you'll see the difference that this makes. So most people want to donate directly one to the other. Why would you go into a scheme like this if you can give to your husband, your child, whatever? But as I've said, sometimes there can be advantages for a better match, either for HLA or age. So if we look at the numbers, and these are taken pre-pandemic, so 112 compatible pairs were included in the scheme from across all the centres. 147 of those exchanges that they were in were completed, and that created 259 transplant opportunities for everybody else. And most of these compatible pairs are in fact transplanted in the scheme within 1 or 2 matching runs. So that's between 3 to 6 months. And then if you don't get a match, you can always come out again. So this is something that we really want to encourage because it benefits the patients themselves, and it also benefits other patients, which again is a win-win. Next slide, please. So the other thing is about increasing flexibility in the scheme. Now, I'm not going to go into all of these in detail, but basically what we do is we have a number of criteria that recipients can request, so age and HLA preferences when you go into the scheme. We have designated timeframes across all centres where we try to achieve all the transplants, because we know that the greater the delay, the more risk there is that transplants won't proceed. We have slightly staggered chains. So even if we identify chains where we would ideally do them all at the same time across all centres in the UK, sometimes that's just not possible logistically. But if you have a very short time frame within maybe a couple of weeks for all those transplants to proceed, then actually that reduces delay and allows the transplants to go ahead safely. And this has facilitated hundreds of transplants by that alone. And then there's always the worry, isn't there, that if you're donating into a scheme like this, well, what if my donor donates and I miss out? Well, we have a system where we can prioritise you for a transplant on the waiting list if that should happen. Now, it doesn't mean it puts you above everybody else, but it does put you above everybody else in your particular bit of the waiting list. And that's been a really important development. Next slide, please. So tackling non-proceeding transplants, what do I mean by this? What I mean by this is when everybody's been matched and everybody knows that they've got who they've been matched with, and then something goes wrong and that transplant or that exchange cannot proceed. And that's hugely devastating. Now, we know that unforeseen things happen to people, and we expect about a quarter of the transplants that are identified that could happen each time. So we aim for 75% of all the identified transplants in the scheme to go ahead. But sometimes that's less than that. And so the real thing we're trying to tackle here is things that you can foresee and things you can't foresee. So we pay a lot of attention to the detail before people go into a matching run, and we will ask you a lot of questions about your circumstances at that time. Are you well? Are you going to be getting married? Are you going on holiday and you can't participate? So if there's any doubt about that, we would say leave you out of that matching run, because this isn't the time for you, but we'll put you back in to the following one. So my mantra is, if in doubt, leave them out. Next slide, please. And we monitor every centre really carefully. Now, I've blanked out the centres here, but actually every 6 months we look at this data, the number of matches by centre, the number of transplants that haven't gone ahead, and why. And then we go back to those centres and we say, is there anything that you could do either with yourselves or with your patients to avoid this happening? So this is a really important part of what we do, and this is done on a survey monkey. Next slide, please. So the really important thing for all of you is how can we make sure that you know about the scheme, and how can we make sure that you have access to it? So it's doing things like this. It's talking to you about it. It's writing articles about it. It's sharing our learning in it, because it is a learning curve. And it's also about how healthcare professionals, how my colleagues make decisions with you and on behalf of you about the best options for you. Next slide, please. So we've had quite a lot of publicity, because this has caught the attention over the years of the media. So first of all, there are resources on the NHS Blood and Transplant website, either in short animation films or in the leaflet that you can see there, online information. So please do look at it. It gives you chapter and verse about how the scheme works. But the 2-minute little video on the Transplant TV films just gives you that overview and makes, how does it actually work for me? There was a lovely article that became front news in The Guardian of these 3 pairs who were all prepared to meet, because of course this is an anonymous scheme, but sometimes people are willing to meet. And this was a beautiful story. Hit the front cover of the weekend magazine. You couldn't ask for more. And it was just lovely. I enjoyed reading it. It was just fantastic and inspiring. And then, of course, on World Kidney Day and things like that, we've been able to show the number of transplants that have gone through the scheme. And at this point, that was 2 years ago, we'd done our 1,000th transplant in World Kidney Week. So that was really rather nice. Next slide, please. And for professionals, it's quite complicated, this scheme. So we provide monitoring reports for them so they can see how the scheme is progressing and the risks and the benefits of it. We provide calculators so they can sit with you in a clinic room and work out your likelihood of being matched in the scheme. And we provide an annual report in which we have all of the information and the data that they need to support decisions with you. And of course, this is your data too. It's in the public domain. Next slide, please. So what difference has the scheme made? Next slide, please. So over the years, this shows adult living donor kidney transplants. And you can see on the far left of the slide, this shows 10 years. And in fact, if we went back 10 years before, we'd find that actually we were only ever transplanting from people who were blood relatives or emotionally related. So friends, rarely, and more often partners and spouses. And over the years, you can see the complexity of the scheme has changed. And now, and although this is very small, those black blocks are the non-directed donors, are donors who donate to anyone on the list. The grey ones are the ones that receive through the pairs and the pooled, so pairing being 2 couples, pooled being 3. And then you can see that the number of incompatible transplants there in the little squares below in the last block are much less. So the growth and the sustainability in the programme is now largely due to the kidney sharing scheme, and it accounts for about 20% of all our transplants. Next slide, please. So this is the kind of report, and if you just ping the slides on probably about 3 or 4 times, you'll find circles come up, and these are all very small, and I'm not showing it to you because I'm expecting you to look at it. I think that's probably it now. Thank you. But you will see that this is provided for healthcare professionals every quarter, and it depicts the matching runs, the number of transplants that have been achieved overall, the largest size of runs, the trend in terms of the numbers of transplants happening, where they're happening, what kinds of transplants they are, and also the impact we're having on the monitoring of the non-proceeding transplants. Now, COVID was difficult, and I'll show you a bit more about that in a moment, and it's created some challenges. But you can see overall there's a lot happening in this scheme, and there's a lot that's benefiting patients. So it's really something that we're really happy is developing in the way that it is. Next slide, please. So the real impact is patients. So for adults, we've reduced the need for incompatible transplants during the lifetime of this scheme. And you can see the dramatic reduction in the requirement for those really quite complicated transplants, either by removing antibodies against blood group or HLA type. Next slide, please. And the same is true for children. And I think this is less well known. I think typically parents want to give a kidney to their child, but sometimes that's just not possible. And actually this scheme gives them a real opportunity to get their child a really, really good living donor transplant. Next slide, please. One of the really lovely side effect benefits of this scheme is the ability to address health inequalities. And again, this data, I can tell this slide will be very small to you, but what I'm really trying to identify here is that for both adults and children, around 20 to 25% of the recipients of kidneys in this scheme come from Black, Asian, mixed race and ethnic minority groups. And that's really important to us because, as we know, there is a disproportionate disadvantage if you're from those groups. And this is regardless of the ethnicity of the donor. So 99% of our non-directed donors are from a white background, but 20 to 25% of the recipients in this scheme have a transplant facilitated for our BAME communities. So that's a result, I think. Next slide, please. And this is just to illustrate on the infographic on the Nhsbt website that slight overrepresentation of living donor transplants, I hope, part of that has been contributed not only to the initiatives that have been running for those communities, but also to this scheme. Next slide, please. So this is one of those horrible statistical graphs, isn't it? That sort of you think, oh gosh, what does that mean? But what I'm trying to show here is that the survival of these transplants, despite the fact that we move kidneys around the countries between centres, are equivalent to a direct living donor transplant. And that's really what this slide is showing you. And importantly, what it's showing you is that the transplant outcome for these transplants is always better than if you have an HLA incompatible or a blood group incompatible transplant. So a compatible transplant is really what we want to achieve for you if you're waiting for a kidney. And if we can do it through this scheme, then that works for me. So next slide, please. So as Peter alluded to, this has now become the largest and most innovative scheme actually in Europe, amongst three others, Spain and the Netherlands. And you can see there the contribution of the scheme in the UK in comparison with those other countries. Next slide, please. So in the last minute, I just want to talk to you a little bit about the future. So we've had a terrible time. You as patients have had a terrible time. So what can we do with this scheme to try and improve the landscape of living donor kidney transplantation for you? Next slide. And next slide, please. So the COVID bomb hit living donation harder than perhaps anything at all, and it has taken longer to recover than deceased donation, there is no doubt. We suspended matching runs out of necessity for safety of donors and recipients, but we are determined now to keep the quarterly matching run going through the next year and manage that so that we don't have these peaks and troughs of activity, and we try and sustain activity through the scheme because it makes such a contribution. Next slide, please. Our greatest opportunity, as many of you will know and have campaigned for, is that living donation and deceased donation sit side by side in the next 10-year vision. The next organ donation and transplantation strategy, that is a UK strategy facilitated by NHS Blood and Transplant, actually has these two things in the same sentence. And living donation will be an expected part of care and offered to patients where they're suitable to receive a kidney transplant. And that is also true for our liver recipients. So there's something for both groups of people in this strategy, but this is a real result, and it is something that I feel absolutely delighted about. So what are we going to do, next slide, with our scheme within this strategy? So we're going to maximise transplant opportunities in the way that we know we can do it best using this scheme, but not forget that some patients will still need to have access to those antibody removal techniques as well, because they may not get a match, however hard we try in this scheme. Next slide, please. So the next strategy will allow us to continue to innovate. It will continue to build capacity to maximise this scheme. We are already starting a digital transformation programme to underpin the scheme and all activities related to living donation. And it's allowing us, as we've already done, to explore options for collaborating with our international colleagues, so that if we can find you an opportunity for a transplant in another country, if we haven't got one here in the UK, that might also be possible. Next slide, please. So the next revolution, next slide, please. The next revolution, I was going to say, I'm sorry, it's when you're not driving your own slide. The next revolution really is about doing all of that and making this scheme as best as it can be for all of you. So in summary, the kidneys sharing scheme has revolutionised our approach to living donor kidney transplantation and definitely antibody incompatible transplantation, and therefore the successful outcomes of transplants for our patients. We know that it's the largest scheme in Europe, and we're very proud of that, but we are actually not so proud that we recognise it still continues to need to evolve and improve. And we need to do that so that we make the most of absolutely every transplant opportunity. So it's a continuous improvement programme. I'm delighted to be leading on that within Nhsbt. I have a fabulous team of people who work from all their different disciplines, as well as yourselves, who tell us what you want out of the scheme. And we have lots more work to do, and we look forward to doing that. Next slide, please. So just to acknowledge all my colleagues, really, I can't name them on one slide. So all my colleagues from all these different places who contribute to this work. And I think that's all from me, but just to my last slide, will just encourage you to ask questions in the last 2 minutes of time that I have available to you. Thank you.
Lisa, thank you very much. What a fascinating talk that was. We've been inundated with questions, and one of the questions was, could we have a copy of this presentation and notes so yes, cascade it to the KPA? Now, what we're going to do is we're going to have a watch again on the website, and every question that's been asked, even if we don't answer it live today, we're going to go to the person who's doing the presentation, get them to answer it, and then we'll go back to you. So absolutely, everything will be able to be seen again and answered. We've also got here that Michael said, is there an age limit for recipients or donors to enter the scheme?
No. There's no age limit. There's no upper age limit. Our oldest non-directed donor was 85, and I followed him around the country as he had he went viral on media, and he was saying I was mowing my lawn in a week, which wasn't entirely realistic, but no, there's really no age limit. It's all done on clinical assessment and suitability to be in the scheme. No age limit.
Brilliant. If you're on the transplant waiting list, are you automatically on the live transplant scheme?
No. In order to be in the scheme, if you're a transplant recipient, to go into the paired pool scheme, you need a willing donor to go in with you. But you may benefit at the end of a chain if you're on the transplant waiting list. So you may benefit from the transplant even if you don't have a living donor, but no, you're not automatically in that scheme. But if you're interested in it, it's something to discuss with your medical team. Really important.
And someone's just put, what a wonderful scheme. My husband was on it, had a transplant, and his life has been transformed. And thank you very much. That's what they've just put. So
my pleasure. Our pleasure, actually. Everybody, this is dear to everybody's heart, and we love what's happened to it, and we didn't foresee it. So if it's making a difference to people's lives, that's all we want.
Sadly, Lisa, we're out of time, but fantastic talk, and we've had so many questions, and we'll forward them all on to you. So our next presentation is from Professor Jeremy Hughes, Kidney Research UK Chairman. Now, Jeremy is going to give us an update on the latest COVID-19 research, future research, and how he wants to raise £3 million. Jeremy.
Great, thank you very much indeed, Pete. Thanks very much for the invitation to speak to you today at this meeting, and I'm delighted to be joining you from Edinburgh, which is not very sunny, I'm afraid. And I hope the technology is going to work for me. It's working, fantastic. So first, although many of you will actually know us well, I wanted to say a few words about the charity and give you a flavour as to the kinds of things that we do. So we fund research in all areas of kidney disease. Transplantation is one example, in children and in adults. And the funding that we provide to junior clinicians or PhD students, that actually helps to increase research capacity, both now and in the future in the UK. We fund research projects, but we also do big things by working with industry. For example, we funded a large clinical trial, like the pivotal study, which looked at iron therapy in dialysis patients. It recruited thousands of patients. And also we fund large programs of research. So again, Peter mentioned £3 million. We recently funded a £3 million Make Every Kidney Count campaign. And that was to fund research aiming at making kidney transplants last longer. The charity can take on big infrastructure projects, and they're actually very important in research. So we worked with multiple industrial companies and the academic community to establish the Nurture Biobank. And that has samples from 3,000 patients who have renal disease and 800 patients who have nephrotic syndrome. And this resource will power research in the future to answer many research questions. And then more recently, we've been quite busy virtually developing some additional national networks, such as medical technology, a data network, and also a dialysis research network. And the aim of these is to bring people together from across the UK to try and catalyze research in these different areas. And I want to give you a brief update because of time on the charity and COVID research and what this might mean for patients. So despite the dreadful impact of COVID-19 on our income, so it hit our income by about 40%, and sadly that meant redundancies, furlough, and a reduction in hours for many of our staff. Despite that, we were being approached directly to be involved in research projects, and one of these is the Protect V study. And essentially, the charity worked with a group of funders, shown on this slide, that came together to fund the project. And this study is now going well. It's recruited hundreds of patients across the UK, and it will determine whether the nasal administration, like a hay fever spray, of a drug called niclosamide, and this drug is previously normally used to treat tapeworm infections, but it is active against the COVID virus. And we want to know whether taking this drug nasally can either prevent COVID-19 or limit the severity of the illness in patients who are vulnerable and high risk. And that obviously is our population of kidney patients, because they're immunosuppressed and may respond less well to the vaccine. So we hope that if successful, this trial is going to add another layer of potential protection for kidney patients, both now and in the future. And I would add actually that this trial has now gone international to India, and we would all have seen the awful situation that was in India recently with COVID. So again, it may, if successful with a positive result, it may be important internationally. So we were then asked to fund a vaccine efficacy project by helping to build a COVID research fund. We went to Andrea at the NKF, and she very kindly put us in contact with the various kidney patient associations. And we were really delighted, actually, that some of you were able to respond. And as a group of funders shown on this slide, it enabled the project to go ahead. And this vaccine efficacy project mentioned by Andrea in her talk earlier in this meeting will focus upon dialysis patients, because dialysis patients are at increased risk of developing severe COVID, and also they have to attend hospital to receive their treatment. Oh, let me go back. So this research, as Andrea said, is going to examine 1,200 hemodialysis patients from across the UK. It's going to look at the immune response to the vaccine, both before they get the first dose and after the first and second dose, and actually after 6 months and 12 months. And the idea is to understand how do patients respond over time to the vaccination. And that data is really vital, because if you don't understand that, the pattern of immunity in a vulnerable patient group, you don't really understand exactly who may be at increased risk despite having the vaccination. And this study is good because it's a big study, and a big study with hundreds of patients can actually look at different factors that may affect the response to the vaccine. So, for example, age, the type of vaccine, as you mentioned, the mRNA versus the Oxford vaccine, ethnic background, and also accompanying health conditions such as diabetes, because that all can impact upon how a patient may respond to a vaccine. Now, at the moment, we are currently working together with 4 other non-kidney patient charities to fund a very ambitious study called the MELODY study. And this study aims to assess the immune response to the third dose of the vaccine in 36,000 patients. I'll say it again, 36,000 patients. Now, 20,000 of those patients will be solid organ transplant recipients, and the majority actually are going to be kidney transplant recipients. But we'll also have patients that have autoimmune disease, that have had immunosuppression, and also there'll be a smaller number of cancer patients that have various cancers. And the idea of this is that we will use the point of care antibody tests that have been used by the REACT study to see whether people in the community are responding to a vaccine or have had COVID. And they're going to send out 36,000 point of care tests to evaluate the immune response to the vaccine after the third dose. And again, this data, it has to be done quickly because the doses are happening right now. But this data is again a hugely valuable to try and identify patients who we think may be vulnerable despite having the third vaccine. And the preliminary thinking before the study was started is that there may be up to 9,000 patients who may still be at risk despite having the third vaccine. So again, a very important study, and that research will be published and brought to the attention of other stakeholders as soon as it's available. Just want to give you a little overview of the charity's future plans and our priorities. And certainly patients were very important in helping us derive our new 2020 to 2030 strategy and in prioritizing what research needs to happen as a matter of urgency to drive forward an end for kidney disease, which is what we all like. And here you can see the strategy, and you can see we've got various things like a vision, a purpose, a priority, and spotlight. One of the things that I personally really like about working in the charity is I think there were these core values of ambition and bravery, urgency and passion. And I think they are the things that really exemplify the charity. And indeed, after hearing Andrea speak to you all this morning, I think actually it probably exemplifies the charity that you are working for patient benefit in difficult circumstances. And we identified some urgent areas that need research, because if we don't have research, we can't really affect change over the next decade. And these were transforming treatments, multiple health conditions, and health inequalities. And Lisa has already mentioned health inequalities and how important that is. So why did we focus upon transforming treatments? Well, it's actually what patients and friends, family and carers of patients actually affected by kidney disease told us. They said that's the most important research probably for us, is actually changing the treatment, making it better, making it kinder, making it more effective. So we really want to raise awareness of the realities of what kidney treatments are like. And again, you'll see a video in a moment, but when you speak to a broader audience, people often think that having a transplant is a cure. They may not think that transplants fail, or they think that dialysis is an acceptable form of treatment. And we, through this campaign, we want to change those views, as you do, I'm sure, and inform those who don't know what it's actually like to live with kidney disease. So the Transforming Treatment campaign was launched earlier this year in May, and I think it's had a really huge traction on social media since then. And the aim is to raise an additional £3 million of research over the next 3 years, specifically in the areas of dialysis, transplantation and medical technology, because I think that's going to have a lot to offer us. And that will then support the transformation of kidney treatments for patients. Now, we are perfectly aware that £3 million is not enough. And therefore, we also look at partnerships with other organisations and also alternative ways to try and fund and drive research forward to make the pot larger and to have greater impact. And this campaign is using real people and sharing their particular kidney stories. And the messaging around it is aimed to be straightforward, realistic, again, with a sense of urgency. And you'll see more of our communications and funding activities supporting this campaign coming through in the coming weeks and months. And actually, we're going to have a gala dinner in April of next year, again, to try and raise funds for the campaign. Okay, so we've got a video here. I'm going to share it with you, where you'll hear from Dale, Seema and Efiria, who are all patients, and also you'll hear from James, who is a clinician from Leicester and a researcher with a big interest in dialysis. Can you play the video, please, Tim?
One of the first things that you're told, or that's explained to you, is there is no cure.
Thank you. Shot one, take one.
Yeah, so I mean, the kidney obviously has got loads of different functions. You know, the kidneys are not as fashionable an organ as the heart, for example, but they play a really important role. But I think what's important to understand is just how common kidney disease is. It's as common as diabetes, and yet it's talked about a lot less.
So my family have been affected by kidney disease quite significantly.
Having kidney disease is my normal. Hospital did definitely become our second home.
I was absolutely petrified. I just landed my dream job, working overseas. Everything just came crashing down.
For my dad, being on dialysis I think he was on dialysis for about 4 or 5 years, and it really did affect his life massively.
You'll just put on so much weight, and I think I honestly put on a stone in less than a week. And it was like it was a very quick and sudden change. I looked different to how I usually did, and it was uncomfortable and I couldn't walk far. And for me, that was the hardest part.
I've been transplanted, and I'm very, very lucky. But I'm under no illusion that I'm fixed. You're living every day with the knowledge in the back of your head that it's a plaster over a problem, and you were just desperate for a breakthrough.
The amount of funding that is given to kidney disease is less than many other chronic diseases. That probably means that the research we would like to do sometimes is not prioritised, and that's not because they're not important research questions, and that's not because they're not research questions that actually people with kidney disease would like to see answered. It's just because there isn't enough funding to do that.
I would hope that the whole dialysis process was able to be easier for those individuals that are having to live with it. It's still a significant amount of time that the individual is having to be hooked up to a machine to dialyse. It also limits the ability to travel, to socialise, to do all the other things that really, make up what we want to do in life.
When I started dialysis this time, obviously my parents remember when I was a baby a lot clearer than I do. I think we were all surprised to see that from patient perspective, obviously, that actually not a lot had changed, which in 20 years, I think just shows that funding is so important for kidney research.
I just want to live a normal life. That's the difficult part, is that I know that's not going to happen without further developments in better drugs, better technologies, better research, better understanding. And the only way that that's going to come about is by raising money in order for people like me to continue to live their life.
The research has got to be the key to getting to the right treatments or mechanisms to be able to avoid people having to suffer in the way that we have as a family.
I can tell you that you know someone who has kidney disease or is affected by kidney disease, and that by donating money to Kidney Research UK, you're going to ensure that the access to care they get is going to be better.
It doesn't matter how much you can donate, because every contribution counts towards funding vital, life-saving research.
Thank you, Tim. I think that video just says so much about kidney disease, how it affects people, their families, and actually what's needed to affect change. And that has to be through more research, better research focused upon things that are of key relevance to patients. So it would be great if you could help us spread the word. And again, you could feel free to share that video on your social channels. You can find it on the charity social channels, or it's on the Kidney Research UK YouTube channel. Moving on a bit to patient and public involvement at kidney research. Again, this is obviously fundamental to the charity. Patients are involved at so many levels as advisors, participants, advocates, and it permeates all our strategic actions. And what we must do is work together as a community. And I think that's a really important word for us to make sure that more kidney patients are informed about research and the outcomes of research, have their voices heard in research and developing the priorities for research, and also have the ability to get involved in research. And I think that can be an issue in terms of equity of access to research. Together, we need to drive the agenda to effect change and change health outcomes for individuals who are affected by kidney disease. And again, it's about building that community. We get resilience through being part of a community and encouraging patients to take action, either with their time, their voice, or their money. But again, that is all very important for effecting change. Now, within the charity, we're very lucky that we have Miranda Scanlan, who is, she follows on from Phil Smith as the chair of our newly named Lay Advisory Group. Miranda is a transplant recipient, tremendous energy. And the quote you see there, again, just highlights the fact that, patient involvement is a huge value, but we must ensure that we make that involvement count, because there are difficulties that can get in the way of patients engaging with the work of a charity because of the things that affect them in their lives. So that's a really important thing that we are aware of, that we want to make all input from all patients count. And the Lay Advisory Group is doing really well. I think it's set to become very influential. There are members who are joining external networks. So, for example, Miranda has now joined the MHRA and is taking a much more active role in all of our discussions, certainly. And I think the aim is to have the creation and optimization of a culture whereby we have a really diverse and inclusive group of patients, and that they have their say in shaping the research that makes a difference to them. And I think under Miranda's stewardship, another great fog that will happen. So a couple of take-home messages for you. So I think kidney research is a research charity, and often people think of that as being lab research, but essentially patients are at the heart of everything we do. COVID has really challenged us, but we've responded. And again, with the help of organisations, including the NKF and the KPAs and other charities, I think we have managed to do something of real value in the space around COVID and kidney patients. And transforming treatments is now this key strategic priority for the immediate future. It's going to run for several years. We need to raise the funds and implement research to try and affect change. And as ever, working with partners is critical. I think we are essentially all about collaboration and working with partners, because that's how we're going to get success now and also in the future. So thank you all very much for listening, and I'm very happy to take any questions you have.
Thank you very much, and what a powerful video, and so true. So we've only got, one subject on many questions, and that's how can you volunteer for these studies? So that's an important area, and it's something that we are keen to improve, because at the moment, what you can do is you can go to the website for the National Institute of Health Research. You can indicate where you live, and that will tell you all of the studies in renal medicine that are active in your area. And that's fine. You can go, if you live in London, you can actually then get engaged in a study. You can approach people to say, yes, can you tell me more information about your dialysis study or your transplant study or what have you? The issue that we have with that as a charity is the fact that it puts the onus upon the patient to actually to go there and actively look at what's on offer and then choose if they want to be involved. We think that a better system would be if a kidney patient can actually, or a family member, I mean, there's research around families, carers, how kidney disease impacts their wider family. People can go to a website, and we want this to be the NIHR website rather than duplicating effort, and they can then give consent to be contacted. So if researchers think they might be suitable or interested in being involved in a study, they can then actually contact them, and then you would have obviously information, time to consider it, and you can then say yes or no. And that then actually allows, in a way, the ability or the opportunities to come to the patient. Now, this happens in Scotland, so we have a thing called the share system, whereby I've signed up,
and actually people can then come and contact me if I could be a control or if I could be involved in a study. It's the same in dementia. There's a website where, as a family member or patient, you can actually get engaged in research, and we want to try and get the NIHR to change their website to allow all patients to be able to just do a one-stop shop, go there and then say, I'm interested in being contacted. Please let me know if there's research in my area. But even now, you can go there and actually find out what studies are occurring in your area.
Brilliant, thank you. Quite a few people have said what a great video, as I touched on earlier. And how can they share this? They've put, I know you mentioned that, didn't you?
Yes. Again, I think it's on the Kidney Research UK YouTube page, so you can share links to that. You'll find a variety of the charity social media will have potentially clips from that video. I agree with that. I think we saw that video in one of our trustees meeting, and literally I think it just gets across, doesn't it, so beautifully and powerfully exactly what the situation is like now. And as Afria said, things haven't changed. And that's got to be something that we must do more about. So again, go to the YouTube page. But again, if you go to the Kidney Research UK on Twitter or other areas, you'll find tweets that you can retweet, etc.
Brilliant. Jeremy, thank you very much for your time. We will have some more people coming up with some great speeches and presentations. Catherine Parker's coming up, renal pharmacist. We've got James Gilbert, consultant transplant and vascular access surgeon at Oxford University Hospitals. But we're going to take a break now. We're going to have a comfort break. We're going to be back at 11:30. So don't turn your feeds off or anything. All you have to do is just disappear, put the kettle on, do whatever you want, and we'll be back live at 11:30 with more people. Thank you very much.
Okay.
Well, welcome back, ladies and gentlemen, to our 40th patient event. So our next speaker is Catherine Parker, renal pharmacist. Now, Catherine works at the Manchester University NHS Foundation Trust. We'll be looking at the role of the kidney pharmacist and talking about a 3-year study she started last year. Catherine.
Thank you, Pete. So as Pete said, I'm a specialist kidney pharmacist at Manchester, and I've been in that role for the last 12 years nearly. So what I'm going to talk about, I'm just going to talk a little bit about what your kidney pharmacist does. So some of you might have different experiences with your kidney pharmacist. Some of them might know them quite well. Some of you might not know them very well at all. So I just want to kind of let you know kind of what we do, how we can help you to ensure you're on the kind of best treatments, and the journey of my role and how kind of patients have helped me kind of shape my role over the last 12 years or so. So if you actually put into Google, what is a pharmacist? I think this is kind of a lot of the perception, and probably the most kind of contact that patients in the community have. So somebody who's based in a dispensary with lots of packets of medication. Now in hospital, we find that actually we're very much kind of ward-based, and we work very much with your kidney team, with the doctors, the nurses and all the other staff involved in your care. So it's very different. Also, we see kind of a different population. So patients in hospital tend to be a bit more poorly, and there are lots of different drugs compared to what you might see in the community, such as drugs that are administered into the veins. And we get involved with providing advice on how to administer things safely into the veins, what kind of doses, how quickly, and supporting nurses on making these up to the right strength to make sure that they're stable. And that might be something as simple as what to mix it up with. So if you put it in a bag of sugar instead of a bag of kind of salty water, that might make it kind of all precipitate into big lumps. And also what's potentially very key with kidney patients is in somebody who's very fluid restricted, looking at how we can actually administer drugs in the vein at the smallest possible volume to prevent kind of fluid overload. And this is just an example of what could happen into the kind of tubing if it wasn't mixed up properly. So hospital pharmacists tend to specialise in kind of different areas, and I've been a specialist kidney pharmacist for the last 12 years. Things that people probably don't see are we get involved in developing guidelines. So we work with the kidney team to develop guidelines to help kind of standardise care for our patients, and also support kind of new staff on the best way of kind of doing things and using medications as well. We do audits to make sure that we're using medicines safely in our patients. And you might see us on the ward rounds with your kidney team, kind of supporting them, making kind of general prescribing decisions about medicines. And we will discuss with you or your carers about changes to your medicines and things that are going on with your medicines when you're in hospital. Now, I've certainly worked with my local kidney patient association to develop patient information for our kind of local patients. And I also get involved in education of our doctors and other renal staff. So I teach on a course at the University of Manchester for renal nurses. And because we all know that, you know, kidney patients aren't always included in some of the big kind of pharmaceutical studies when they're testing new drugs, we find it more difficult sometimes to kind of identify what are the best treatments for kidney patients. So we work with the team together to kind of look at what evidence or data there is to kind of come up with the kind of best treatment plan for that patient, and then discuss with the patient the options that we have. I'm thinking about planning medicines timing in relation to dialysis. So should it be given before or after? Do we need to give extra doses? I just thought I'd give a few examples of how we might get involved in your care. So this was a patient who had just started hemodialysis, and they were newly diagnosed with an allergy to heparin. So as most of you will know, we use heparins to kind of stop the circuit clotting up. So it was kind of, what are we going to use now? Looking at our options, what's going to be the safest, and then kind of putting that plan in place. So we had to work with the nursing team because special monitoring was needed. The medical team, because we don't use it very often, making sure we kind of got the right dosing strategy, and also making sure that the dialysis unit was able to get hold of some of the drug. Another example, so at Manchester, we're quite fortunate that we have a dedicated kidney transplant patient phone line, so kidney transplant patients can ring us up with their questions. So this is a patient who's got a urinary tract infection, and their GP started them on trimethoprim, and they're just wondering whether this is appropriate. So we can get involved in calling the GP to discuss kind of what results they've got. Is there any kind of alternative antibiotics that we could perhaps use? In some cases, trimethoprim wouldn't be the most preferable antibiotic, but it depends on the options. So then we were able to work with the GP and recommend a different antibiotic. So they were able to send the prescription that the patient could take. Obviously, during COVID, lots of things have changed. So the way we work, certainly within our kidney transplant clinics and some of our other clinics, is, you know, making sure that patients have actually got supplies of their hospital only medicines. So that might have been, we actually started posting medicines out to patients on a more regular basis, or doing a kind of collection point where patients could collect medicines to make sure that they don't run out of essential supplies. So these are things like the kidney transplant anti-rejection medicines, patients on tolvaptan, and also making sure they had, you know, the blood tests to make sure it was safe to give them, and that might have been organising those more locally to their home. Supporting delivery of the COVID-19 vaccines in some of our clinics, and also across the dialysis units to make sure that dialysis patients had very, urgent access to those kind of vaccines, and that we kind of got that rolled out quickly. And reviewing ongoing kind of treatment recommendations and changes that were happening throughout the pandemic. So there might have been different recommendations for certain conditions. One drug might have been preferred over the other because of less hospital contact. And so adapting to kind of all these changes that were going on as well, making sure that the safest and most appropriate treatments were available for our patients. So where you might see your kidney pharmacist, or this is probably nationally where you might find them. Some units have dialysis unit pharmacists who provide medicines review and advice service, so you might see them on your unit. Your renal ward, when you're in hospital, discussing with you around different changes and supporting kind of decisions. In clinics, so at Manchester we're just involved in the transplant clinic, but there are other trusts who work with kidney patients on tolvaptan, who work in anemia clinics, and who work in some of the kind of autoimmune kidney clinics, looking after patients kind of immune suppressant drugs. Or you might find us kind of working collaboratively, developing patient information, or as part of kind of research. So what can your kidney pharmacist help you with? So I get quite a few questions actually on vitamin supplements, over-the-counter medicines and herbal kind of products. And this is data from a German study, which was quite surprising to me actually, how high the use of vitamins were in patients with CKD stage 4 and 5. Now, this wasn't prescribed vitamins. These were vitamins that patients were kind of buying themselves, because there are some vitamins that potentially can't be taken in kind of the more advanced kidney disease. And actually 5 to 6% of patients were taking herbal or supplements as well from kind of health food shops. So there was quite high usage, which was quite surprising to me. So some of the things I've been asked about in my role, certainly a few years ago, there was a big rage about CBD oil. I was getting kidney transplant patients, dialysis patients, can I use this? So they're very difficult kind of herbal medicines because they're not regulated like medicines. So we know exactly what's in some of our licensed medicines, but it's very difficult to know the amounts of things that are in some of these kind of herbal products. And when I looked into it, I found some information that perhaps it could affect the way the body handles certain drugs, such as tacrolimus, cyclosporin and tolvaptan. So that kind of raised concerns with our transplant patients and some of our kind of rare kidney patients who might be taking these drugs. The other issue is can be some active cannabis in this product, which relies on the kidneys for removal. So the more severe the kidney disease, the more potential for some of the side effects, including kind of some of the mental side effects and sleepiness. And one of my colleagues who's worked down in London, she's actually got some data from a couple of patients who took CBD oil who were kidney transplant patients, and the levels of tacrolimus kind of became erratic, and when they found out it was the oil and they stopped it, they kind of came back to normal again. Another thing that's kind of become more popular is turmeric, and again some of the data says it can affect the way the body handles things like tacrolimus and cyclosporin. Now I'm not talking just normal amounts of turmeric that you might use in your cooking, something that you do kind of day in day out. I'm talking kind of very big doses, or some of the capsules you can buy, and we have had patients using the capsules that it has actually increased their tacrolimus levels. Things over the counter. So I do get quite a few questions about the use of ibuprofen gel. So it's very individual decision. It might depend on the patient. Occasionally we do use it very short term, but we would do that in conjunction with the team and kind of make a decision as a team about how appropriate that was. And I get lots of questions about cough and cold medicines, because we know that some of them contain ingredients that can affect blood pressure. And the problem is there are so many medicines out there, it's difficult to know which one's which. So I would always suggest speaking to your kidney pharmacist or your kidney team before kind of taking anything herbal particularly, or over the counter. And we do also get involved in providing vaccine and travel advice for people going on holiday. Obviously, at the minute, that's probably been much lower down on people's priority lists. So how does the kind of kidney patient data kind of help us to kind of support you with your medicine? So we actually undertook some local data in our dialysis patients and found that patients who were on our in-centre dialysis were taking 16 tablets every day. Now, I think that's really important for us to understand that the actual kind of effect that might have on somebody's life. And patients were describing to me, I feel like I would rattle if you shook me because I take that many tablets. And a French study looking at non-dialysis patients found that patients with CKD or CKD 3 or 4 were taking on average 8 tablets a day. And they actually found that over 2 years, nearly 20% of these patients were experiencing side effects from their medicines. And some patients were having lots of side effects, more than kind of just one. So I think it kind of, raises the concern to us. We need to be aware of kind of the significant amount of tablets. So we really need you to kind of let us know if there's certain tablets that you started that you're really kind of struggling with, they make you feel terrible, you're not taking them. If you think you're getting side effects from your medicines, please let us know, because we need to work with you to find the actual kind of best treatment for you. And certainly, if you don't know why you're taking a certain medicine or what the benefit of it is, then please ask that, because it makes it very difficult for you to want to take something when you're not really sure what it's for or what the actual benefit is. This is just a little bit of local data, a little sample of when I was doing some dialysis reviews from 22 patients, and we actually found, because I was doing kind of direct questioning, going through medicines and actually spending time with patients, talking about their medicines properly, allocating, specific time to go through all this, we actually found that I managed to stop at least one group of medicines per patient. So that may have been more than 1 tablet a day. And we identified that actually patients weren't taking at least one of the kind of tablets they were supposed to be taking each day. Some patients were taking things they shouldn't have even been on. And nearly a third of patients were experiencing kind of side effects from their medicines, but they hadn't kind of alerted this to anybody. So maybe it's us as well. Maybe we need to be a bit more kind of vigilant about these things, but please kind of highlight these things to us, because what can happen is you get into a prescribing cycle where you start things that actually are just to treat a side effect rather than treating you. So how have patients shaped my work over the last 10 years? So they've had quite a big influence on my role in transplant clinic. I get lots of questions from patients, and it's led us to kind of start developing different information that we can hand out to our patients in clinic on common questions. just from talking to some of my kind of older kidney transplant patients on the ward, some said they felt like they missed their friends from dialysis, and I felt like they were staying in a bit longer than some of their younger counterparts. So I actually did a kind of small research project looking at, how often they came into hospital, their infections. And what we found was we had very high levels of drug toxicity in our older kidney transplant patients. And this was leading to admissions in quite a lot of them. So we've actually changed our kind of anti-rejection regime for that kind of population. But I think what it really highlighted to me is we know there's the survival outcome data there for older kidney transplant patients, but what about quality of life? I think it would be really interesting to actually look at the actual how patients feel after they've had a transplant and the actual impact on their life. So over many years, we've kind of developed these more effective kind of dialysis machines, and there's uncertainty as whether they remove more drugs. And actually, some patients were saying to me, I feel like I'm kind of withdrawing from my painkiller medicines when I'm on dialysis. Like, it's a really strange kind of feeling. So I undertook a small study with the University of Manchester and one of our nephrologists, and we've kind of looked at kind of what happens to the dosing of these drugs and the levels during a dialysis, and we're just in the minute kind of analysing that data at the minute. So a difficult area for me, my practice has always been kind of blood thinning drugs, because lots of patients tend to need them because they're at higher risk of having kind of clots, but they're also at higher risk of having bleeding. And a lot of the drugs we use aren't studied in kidney patients. And I think what I find really frustrating is there's lots of information out there for people with normal kidney function when starting these kind of medications, but we just don't know what to tell our kidney patients. We don't have the information. So what I'm currently doing is I'm undertaking a research project which is funded by the National Institute for Healthcare Research. And I'm working with a professor of kidney medicine, a consultant in blood disorders or haematologist, and a pharmacist from the University of Manchester. And I've got a fantastic kidney patient who's helping me, who's this topic is very close to his heart, and he's been fantastic throughout the process. So the overall plan of this work is to develop a national guideline with some kidney patient documents in there, and I'll talk about that in the next slide. Now, I have had support from my local kidney patient research group, and they provide me with some fantastic ideas and feedback. I'm also working with the Devices for Dignity, and they have some PPI patients that can support me, and I had some assistance from a patient advocacy officer from Kidney Research UK when we were looking at starting the project, just to do some scoping work to see what patients thought. So what the study, the patient kind of part of the study is going to be undertaking some online focus groups or kind of just some online discussions with kidney patients who have ever kind of taken blood thinning drugs or are currently taking them now. So that might be warfarin or apixaban or rivaroxaban. And what we really want to kind of understand is their experience of kind of what information was provided when they started these drugs. Was there anything they felt could have been done better? And what would other kidney patients who are going to be starting these drugs in the future want to know? And can we kind of develop something to help support patients when making these decisions? And it's all about kind of developing information to support discussions between the team and the patient. So this study is kind of raring to go. So if anybody does feel they would like to have their say on this topic, then I've just put my email on the last slide. So please do get in touch if you think this is something you would really like to have your say on. Thank you.
Thank you, Catherine. Well, such an important role, but one we've never touched on before at NKF conferences. I'm really glad we did today. So Lisa has just put on the chat. Thank you very much for highlighting the use of herbal supplements. I think it's really important that it should be discussed more with kidney patients. I know you spoke about that. What's your thoughts on that?
Yeah, I think since I read that paper, I've actually started asking kidney patients more about whether they've considered herbal supplements or whether they actually take anything. We try to do that in our role anyway, but I think I always assume kidney patients wouldn't do that. But, you know, I think that it's word of mouth, like lots of people get talking, oh, this has been really beneficial for me. And I think it's thinking about it, isn't it? Like the impact it might actually have on your kidney medicines, particularly the transplant medicines. That is a potentially big impact, isn't it?
Yes, definitely. So would it still be okay to take vitamin B and C, Hope has asked, and she's a dialysis patient?
Yep, so we give vitamins, we do give specific vitamin supplements to most of our dialysis patients, and that would contain things like vitamins B and C. The main ones to worry about are things like vitamin A and taking too much vitamin D if it's kind of above and beyond the recommended levels, and depending on what other kind of vitamin D that you might be taking.
Thank you. And last question then, someone's put, I've missed your email address. Could you show it again, please? Because they want to contact you. That's a challenge, isn't it, for you now?
Thanks, Pete.
I think it'd be the back. Would it be the back
I will
button?
just say, note the spelling of Catherine. There's no E in it.
Lovely. Well, thank you very much, Catherine. Very enlightening. Now, our next speaker is James Gilbert. He's a consultant transplant and vascular access surgeon at Oxford University Hospitals. Now, James is the president of the Vascular Access Society. He leads the vascular access program in Oxford. He's going to be talking about new methods and his experiences. Now, I've seen James talking before, and it is absolutely fascinating. So over to you, James.
Well, good morning to you all. Well, it's nearly the end of the morning, may even be afternoon. Good afternoon to you all. A huge thank you to the National Kidney Federation for asking me to contribute to this really exciting patient day. I'm James Gilbert. I'm a transplant and access surgeon in Oxford, and I've been asked to talk to you a little bit about endovascular arteriovenous fistulas for dialysis. I have a few disclosures to bring to your attention as I start, and I think the big disclosure is that in my talk, I've got a number of clinical pictures of fistulas, some that look nice, some not so nice. So if you're squeamish, I'm just giving you that information now. As I do start, I want to say a huge thank you to all of you. As a clinician, I absolutely love doing the job I do as a transplant and access surgeon. And that's because of working alongside many, many patients like you. We as clinicians couldn't do what we do without your input, without your feedback, without your partnerships. And I think that's one of the great things about kidney disease, managing patients with kidney disease, that we work in a partnership, and you are seen as equally important to that from our perspective. So thank you for all that you do and for all your contributions to kidney care and also to today. Many of you will have seen this slide before, but what this slide is essentially showing is that in the years gone by, the number of patients in the UK that are needing renal replacement therapy of some form is increasing year on year. And the different coloured lines here show those patients who are getting transplanted in the dark red, those who are on in-centre haemodialysis, those on peritoneal dialysis, and those on haemodialysis. And we know that for patients going on to dialysis, your outcome long-term, the longer you remain on dialysis, is not good for you. And this slide shows that here. It shows us that your survival over the course of time fares less well compared to somebody of the same age group who is not on dialysis. And depending on your underlying cause of kidney failure, you have a less good outcome longer term. So diabetics on dialysis don't do well the longer they remain on dialysis. And it's for that reason we are really keen that as patients come in to land on a dialysis machine and need to start dialysis, we ideally want to get them transplanted. And the thrust for many of the patients that we're looking after is we want to see if we can get a kidney transplant in as timely fashion as possible, ideally before they start dialysis or at least fairly soon after starting dialysis. Transplantation is not always possible, though, for some patients, and it's not always possible at the point you need to start renal replacement therapy. And in that situation, we need to get access in place so that you can have dialysis. One of the key things we need to decide on is what modality or type of dialysis you're going to have, whether it's hemodialysis or peritoneal dialysis. And if we're going to do hemodialysis, there needs to be some assessment undertaken regarding what is the right access for you. How do we start you on dialysis? What's the best thing to undertake for you? I'm a great believer that I want to avoid lines for dialysis as much as possible, because we know that lines left in patients long term can cause problems. I don't have time in this talk to go into that, but that is something we do know. And that's one of the reasons we very much look to try and get fistulas created for patients if they're going to have hemodialysis. So if you're a patient who decided you are going to have hemodialysis, some other things we might think about: is it going to be in hospital or at home? There's no right or wrong around that. We need to look at what's the best option for you as a patient. Take into account things like your home situation, your work, family support. Other things I would contemplate is, are you left-handed or right-handed? The reasons for that is if you do home dialysis and you need to cannulate yourself, you want to be able to cannulate with your dominant hand. Are you still at work, as I've said, and you're factoring dialysis sessions around your employment so that we can maintain as much quality of life as possible, despite the challenges of having to start hemodialysis? We need to have a look at whether you can actually have an arteriovenous fistula, and if so, what kind could we create? We classically look at whether we can create a fistula at the level of your wrist, the so-called radiocephalic fistula, whether we might do it at the elbow region, a brachiocephalic fistula, or whether we have to start looking in your upper arm at deeper veins and moving those veins around, a brachiobasilic fistula. Sometimes for some patients, they have no veins that we can use, and there isn't an arteriovenous fistula option, and we have to place an artificial vein or a graft and put grafts into patients. I'm very much a visual person, and so here are some pictures to kind of describe what we're meaning here. The pictures in these slides show wrist fistulas being created, the radiocephalic, or on the right of your slide, you can see a brachiocephalic fistula there, where a vein has been joined onto the side of an artery at the level of the elbow to get a fistula ready for dialysis. Sometimes there aren't simple veins to use in the arms, and we have to dig out the deeper vein sitting on the inside of your upper arm, the so-called basilic vein, and move that across from its deep position into a more superficial position so that the dialysis nurses can place needles. It's quite a big operation and a big undertaking, but this is what you're invariably left up with when you have that procedure. And as I mentioned, sometimes patients don't have veins that we can use, or they've exhausted all vein options by having lots of fistulas made over the course of time and need to have an artificial vein or a graft inserted into the arm. A graft relies on there being an artery at one end that can put flow into the graft, and then a vein somewhere at the other end that you can land that graft onto. And this is a four-arm loop configuration. But we can make grafts and place them in the upper arms as a straight configuration, or sometimes we can place them in the legs. Whatever we're doing though, whatever access we're looking to create, whether it's a simple fistula at the wrist or the elbow, a more complex movement of a deeper vein or a graft, we're trying to get access created so that patients can have needles put into those fistulas or grafts, and they can have blood taken out, put through a dialysis machine and put back into the circuit repeatedly over a 4-odd hour period. We want to be able to get good pump speeds on a dialysis machine, and an underlying fistula working well will do that. We want to ensure that we've got good pressures on dialysis, the venous and arterial pressures, so that patients can process good volumes of fluid through the course of their dialysis episode and ultimately come out at the end of it with what we would term excellent adequacy. And by that, we mean being able to clear waste products really efficiently and any excess fluid that's on board during that dialysis session. We know that we can achieve that for patients if we have what I call a patent access circuit. And by that, I mean what you see in this slide here. This is a fistulogram that's been done. And what you can see at the very start of the fistula is flow going into the fistula vein and then running all the way freely up the arm through the central veins to the chest and back into the heart with absolutely no hold up to flow at all. I like cars, I like traveling, and I often use analogies of motorways. A good working vascular access circuit, fistula circuit, is one where you've got 4 lanes of motorway traffic that run freely with absolutely no hold up from the start to the finish of the route, as you see in this picture here. But sometimes fistulas don't work for patients. And when we look at the data out there, we can see that there is quite a high primary or early failure rate of fistulas that get created. Depending on what literature you read, that can be between 30 and 50% of patients. And I'm sure there's many of you out there who've had that experience. You've had a fistula made, it seemed to have worked at the time of creation, but within a few weeks it stopped working, or it may not have even worked from the outset. We also know that those fistulas we do get working at the time of creation, that a year on, the functionality of those fistulas isn't as high as we would like. They have patency rates that are only around 50 to 70%, and many patients are needing repeated procedures, and some of you will have gone through this, fistuloplasties, to keep that access working and running well. And if they do work, if these fistulas are working well, they can become quite large and unsightly. They require often regular maintenance to keep them in good working order. But they can also block off, they can bleed, and they can be lost. And here are just a few, I'm sorry, slightly gory pictures of things that can happen to fistulas. They can become huge and aneurysmal. They can get blocked in the motorway, if you like, that leads to a build-up of pressure back in the arm, causing arm swelling. Or they can have problems around needling sites that can put them at risk for bleeding. So could there then be a better way to try and get fistulas or access made for patients that would have, if you like, better long-term outcomes in terms of patency, not needing interventions to keep it working, but also not becoming unsightly, swollen, aneurysmal, as you've seen in some of those previous pictures? We'll enter the role of the endovascular arteriovenous fistula creation. This is a relatively new and novel non-surgical approach to making fistula. It's done in a radiological department, and the way of making endovascular fistulas is one where we look to create a network of fistula veins in an arm rather than just a solitary fistula vein running up the arm. This may have some better outcomes, as I'm going to show you now. There are 2 devices available at the moment to create an endovascular fistula. There's one that's the wavelength system, and the other is the ellipsis system. They both have similar principles in what they're trying to achieve. These principles are essentially that we are looking to create an arteriovenous fistula network in the arm where we get fistula flow into as many of the veins as possible, the superficial veins as possible. And to do this, we need something called a perforator vein to be present in patients. Down in the level of the proximal forearm, there are a number of veins that come together superficially, and they're fed by a deeper vein, perforator, that enables venous flow to run from deep to superficial systems and vice versa. We can see that here in this slide. You can see the perforating vein being labelled with the purple arrows. And what happens with this perforating vein is it means that flow can move from deep and superficial veins in the arm. Approximately 75% of patients have suitable anatomy in their arms and have this perforator vein, and its presence means that you can potentially create endovascular fistulas. If you have a look at where that perforating vein is on the slide, you can see it sits very near to the adjacent arteries around that level, which is important when it comes to these endovascular fistula creations. Just introducing the wavelength system for you now. This is a system that's owned by BD Bard. It's a radiological system. And what we do with this is we place a couple of catheters, one into the radial artery and another into the vein that runs alongside it. These catheters are brought up to the level of the elbow region where that perforating vein sits. And the catheters have magnets on them that draw them together, and a little bit of heat is fired for about 2 seconds to create a hole between the artery and the vein that have been magnetized together. And it now means that arterial flow can go into this vein. Because it's just beneath the perforator vein, the flow then runs from this perforator and up into the superficial veins, making a fistula. The ellipsis system also works in a similar manner in terms of it requires this perforating vein to be available, and this video just explains this to you. Under ultrasound guidance, a needle is placed into a vein in the antecubital fossa. It's pushed down to where that vein sits near to the artery and advanced into the artery, and a guide wire is advanced down the artery, connecting the artery and the vein together. The ellipsis catheter is then put over the guide wire via a sheath which is just being inserted here. Here comes the catheter now for creating the fistula. It's got 2 components on it that pull together. And once you advance this into the artery and then remove the sheath, what you can actually do is create a hole between the adjacent artery and vein. And once that's been done, it will enable arterial flow to run into the adjacent vein. And again, because it's quite near to the perforating system, it feeds up into the more superficial veins of the arm, giving fistula flow in these superficial veins that can then enable the veins to mature and be used for dialysis. The 2 devices have a number of similar but also different properties. I won't go through all of them here. What I would highlight though is that the wavelength system, because of the way it's set up with the catheters, is it does mean you could create the fistula a whole different range of levels between the artery and veins of the forearms, whereas the ellipsis system exclusively is around the level of the proximal radial artery near to the elbow. So there might be more flexibility with the wavelength system. What you've seen in the videos and what I've tried to explain is that once you join that deeper vein and artery together in the proximal forearm, because of the perforating vein being there that sends flow up to the superficial veins, you have a result where this arterial flow that's now running into the veins can split and feed multiple veins in your arm, the upper arm cephalic, the basilic, the forearm cephalic. And so you get this network of lower flow rates going through multiple vessels rather than a single vessel. And this might actually give more cannulation options for patients, perhaps with the low flow compared to just a standard surgical fistula. You possibly would end up with less of an unsightly, tortuous fistula that can be expected with surgical ones. This is what the fistula creation looks like angiographically once it's done, but perhaps more importantly, what it looks like clinically. This is 2 weeks after an endovascular fistula creation, and you can see here we've got prominent veins that can be used for dialysis, but it's not just one vein that's been created. You can see that there's a number of veins that are opening up that could receive needles at varying points. So there's increased surface area for needles. These are some endo-AVFs over the course of time, showing you the considerable less disfigurement associated with the endovascular fistula creation compared to surgical creation, with increased flexibility of where needles can be placed. How about outcomes? In some of the early literature we've got, well, one of the very first trials to look at the impact of endovascular fistula creation, looked exclusively at the wavelength system. This was the NEATS trial. And what this showed is that there was 98% procedural success, but more importantly, 91% of those fistulas created did mature to potentially be used for dialysis. If we then have a look at what happened to those endovascular fistulas over the course of time, we can see some really good patency rates out to a year and beyond, where the primary patency rates were nearly 70% with the endovascular fistula. And although there were interventions needed to maintain patency, that patency rate after interventions was as high as 84%. If you compare that to a surgical cohort of fistulas, and this was a meta-analysis done alongside this that looked at outcomes of surgical fistulas, you can see the outcome data was a little bit lower, with primary patency of surgical fistulas being 60%, and then the secondary patency, those working after interventions at 1 year, 71%. So quite a bit lower than the results we were seeing with the endovascular fistula creation. Since then, there's been quite a lot of experts using endovascular fistula creation techniques globally. A number of them have been presenting and reporting their data in the journals. And here are a few studies that have been reported over the last few years using the two different systems, the number of patients in each of the studies, and in some of those studies, some really encouraging data around functionality and usability of the fistulas quite early on and the time to needling. More recently, there was a systematic review that looked at all of these papers to try and work out whether endovascular fistula creation could be a game changer. It looked at the outcome data at 6 months and 12 months and found that it was very encouraging for these endovascular created fistulas. But the conclusion was that although it appears to be a system that's effective and safe and with good outcomes, because there hadn't really been a lot of head-to-head comparison with long-term surgical fistula creation, no one could say just yet whether it was truly superior or not, particularly given it's a fairly new, novel technique. More recently, Nick Inston and the Birmingham group have published a study looking at a comparison group of surgical fistulas versus endovascular created fistulas in their unit, and they have actually found that although technical success is similar in the two groups, when you start looking at the outcomes at 6 months and beyond, the endovascular groups appear to be doing better. So that's led to the possible pathway of how we might bring endovascular fistula creation into everyday clinical practice. Particularly given that there is a cost associated with the process, we have an algorithm now where, if possible, we'd look to make fistulas at the level of the wrist if we can do that. But if not, before jumping to making a fistula at the level of the elbow surgically, there should be some consideration as to when an endovascular fistula could be created in the first instance. If it can, we should look to do that. And that still gives us the opportunity longer term to make fistulas in the upper arm surgically, even after endovascular creation has occurred. So as I bring all this to a close, I think what I want to say is that an arteriovenous fistula still remains the best way for patients to dialyse if they opt to have hemodialysis and there isn't transplantation available. We know from literature long term that surgically created fistulas are associated with high failure rates. And even when you get fistulas to work, they do require interventions to maintain their functionality over the course of time. The endovascular fistula creation technique is a new technology. There are 2 devices available that work in a similar principle where they're looking to join the deep artery and vein of the proximal forearm together to enable flow to run through a perforating vein and create an arteriovenous fistula network in the arm. The data surrounding these is very encouraging with lower reintervention rates. And what we see in patients with this low flow network of fistula veins is greater area to put needles in and possibly greater long-term data around outcomes of these fistulas, although we do need more data to make conclusions. There is a big upfront cost with making endovascular fistulas that's being worked on at the moment, but it may well be that in the course of time, we find that these upfront costs provide a cost saving compared to all the interventions that are needed for patients, not to mention the huge impacts on patients of constantly having surgical fistulas created that are potentially prone to failure. So I leave it there. I hope that's provided some insight into new technologies in making access and the importance of access for you, and look forward to some questions with you now.
James, thank you very much. Very informative, and I think in layman's terms as well. So talking about this new technology, if patients wanted this method, is it available and where?
Yes, it's available. There are a number of centres that are using the technology. My friend and colleague Nick Hinton and Rob Jones in Birmingham have probably got the biggest experience in the UK. We're doing some in Oxford. Oni Jafar is doing some in London. So there are increasing numbers of centres in the UK that are using this technique.
So do you think in years to come this is going to be the preferred method?
I think it probably will. I think we'll probably always look to see whether we can make a fistula at the level of the wrist first, conventionally. But I think before we go to making fistulas at the elbow region surgically, we will look to try and use this technology in patients if they've got the perforator vein that I described available, because I think they'll have better outcomes by having a lower flow network of veins that you can put lots of needles into.
So does this work with someone with small veins?
So it's a bit like a surgical fistula. You still need to have a vein of a certain size, and we know from lots of the literature out there that your vein ideally needs to be a minimum of 2 millimeter diameter at the time that we create a fistula, if you've got a high chance of it being successful in fistula creation. So we still have a requirement that both the perforator and your main veins need to be around that 2 mil, but as long as they are, there's no reason not to attempt to try and make this fistula.
And John has put, what is the risk of leaving fistulas in stable transplant patients in the terms of cardiac function and the risk of bleeds if damaged?
Yeah, so that is a great question. It's one we're constantly debating in the access community. And in fact, this past year, most of the virtual meetings I've been to internationally, we've been talking a lot about long-term effects of fistulas on patients' cardiac status. And we know that when you've got a high flow fistula, and many patients are having their fistula flows measured on dialysis, if it's high flow, that can have impact on your cardiac function. The general view we've now got in the post-transplant setting is if you've got a patient who's got really difficult access, it's really difficult to bleed them and get blood from them, and they've got a working fistula, I quite like to keep it because you can use that to do the blood taking and do the blood tests. But I think if you've got a patient who's got easy to access vessels, they've got an unsightly fistula, it's very high flow, and they've got a good working kidney, I have a lower threshold for tying those fistulas off and getting rid of them because I think that's more protective for patients long term. That's not a globally shared view. There's not lots of evidence on that, but that's just been my approach and an increasing approach from a number of clinicians now.
And Tracy's put on here, very interesting speech, thank you. Hope has also said, great speech, thank you. And that concludes it, James. Thank you very much for your time today.
My pleasure, thank you to you all.
And our next speaker is James Higgins. Now, Stephen Higgins. Stephen is a dialysis patient from Suffolk who has had a transplant, Stephen is a dialysis patient from Suffolk. He's on the transplant waiting list and has his own filmmaking company. Very fascinating gentleman. I often talk to Stephen. Let's hear his story.
Hello, everyone. Thanks, Pete, for that introduction. I guess with these things, it's best to start chronologically. So I'm going to talk from my childhood and then bring us up to date. So I had quite a disrupted childhood. I was in and out of care quite a lot from a very young age, from 7 or so. And by the time I got to adolescence, I was in and out of various foster placements, some of which were successful, some of which broke down. And around about that time, I was beginning to experience mental health challenges, and I ended up attempting suicide by overdose 2 or 3 times in my adolescence. Fast forward 30 odd years later, and I find myself with food poisoning, walking into Addenbrooke's A&E one Christmas Eve. And I distinctly remember the worried look on the consultant's face when he came back with my blood results and asked me if I had any history of kidney problems in my family. And I said, no, none at all, none I could think of or remember. So he said, well, we're a bit worried because your kidney function is at 18%, which I took the usual male approach to, which like 18%, that's not bad. Could be a lot worse. I can get on with that. So I pretty much ignored that and was discharged, was treated for my food poisoning and was discharged. And was then contacted by, I guess, having been in A&E, that started some sort of process, because I was then contacted by the low clearance team who deal with people who are pre-dialysis. I was specifically contacted by Nikki Moncrief. Some of you might know her. I think she might actually be listening. I owe that woman a huge apology, because I know how difficult it was for her to get hold of me and convince me that I actually needed some treatment. Eventually, she rang me at my desk at work, and she said, like, how are you feeling? Like, do you feel tired and stuff? And that started to clue me in. And then I said, when you say I've got 18% kidney function, do you mean it's reduced by that amount, or I've got that amount left? And she said, no, that's what you've got left. That's the point when it hit me, and I realised that I was unwell. So I started cooperating a little bit more with the low clearance team, and I was seen regularly by them, and we were beginning to discuss dialysis options. And I went along to a dialysis training morning once I'd settled on peritoneal dialysis as at home as the treatment that I will take on. And in the beginning, it was very difficult to get used to. Those of you that have had PD will know that part of it is you need to carry this fluid around in your abdomen for a number of hours, and that can cause an odd shape in your abdomen, and that made me quite self-conscious. Also, I'm not that good at this medical stuff, clearly, because over the next year, I ended up with sepsis twice. The second time, they brought me in and removed the catheter from my abdomen, and then I was in hospital for a bit. And we had a discussion between the doctors and I, and we decided that we were going to switch to HD. So that's it. So then, and then I went into Addenbrooke's for an operation, and in one operation, they removed the catheter from my abdomen, inserted a catheter in my chest, and built a fistula in my left wrist. It was at this point I also quit full-time work and decided to start my video production company, Bigger Pictures, that Pete mentioned. So I had the fistula, and I was having dialysis through the fistula, which meant I was being needled 3 times a week, which I found, I'm not going to sugarcoat it, it was extremely painful. It's one of the worst pains, and I've had gout and all sorts. But the needling I found it extremely painful, and I didn't find that I was having more efficient dialysis than I would through the chest line. So I was quite put out by that. And as the situation stands, sorry, I'm jumping ahead of myself there. So I was being dialysed through the fistula, and then one morning at 9 a.m. I got a call from the transplant team telling me that there was a kidney in Addenbrooke's. I need to be there the next hour to prepare for transplant, which everyone else was a lot more excited about than I was. I mean, of course, I wanted to come off dialysis, but facing down a transplant operation was quite scary, and that's the only thing that I felt going into hospital was fear. Anyway, I went into hospital, had the transplant operation. The next day, when I was taken off my patient-administered pain meds. I was just in excruciating pain. I was in agony, and they couldn't figure out why. So I was taken back down to theatre, opened up again, and they found some clotting on the kidney, which they sorted out, closed me up, sent me back to the ward. And the next morning, again, once I was off of the pack, I was in extreme pain, like agony, like the worst pain possible. I specifically remember begging them to put me to sleep. That's how much pain I was in. So they took me back down to theatre again, and this time they removed the transplanted kidney. So I've gone through 2 or 3 days of excruciating agony. I have a really ugly scar on my abdomen, and nothing to show for it. I'm back on dialysis at the moment, and I'm back on the transplant list, waiting for the next one. But as well as all that happening at the moment, I'm working with the NKF on a mini documentary looking at home dialysis for patients. But I think we'd both like to do something a bit more in depth and a bit more long form if we could get the funding. So anyone's listening who fancies funding a documentary, please do get in touch. But that is pretty much my story. That brings you up to date. So I think I've whizzed through that. I definitely covered everything. Pete, are you there?
Yes, thank you very much. Yeah, you certainly whizzed through it, didn't you? Which means we can have a longer lunch break. But yeah, you have been through the mill, and it just makes you appreciate, things when you're not a kidney patient like myself. So thank you very much for your time, and also thank you for all the work you're doing with us at the moment with the mini documentaries and things. And once they're produced, we'll put them on our website as well. So thank you very much to Stephen. We're going to break for lunch now, and we're going to come back at 1:10. So we're going to have a longer lunch break. If you do want to chat to people, because this is a virtual event, and normally if we'd had a face-to-face one, we'd all go into the canteen or whatever, or the restaurant, and have a chit chat with each other. We're going to have a breakout room. So the breakout room is in the top right-hand corner. It's called Lunch Networking. You can pop into there and have a chat with each other like a normal Zoom meeting. And then after lunch, footballer Andy Cole is going to be talking about football, mental health, and his battle with kidney disease. Fascinating talk. So if you'd like to come back at round about 1:10 in the same link, if you do go out of this link, come back into it again. We'll see you at 1:10. Thank you. Ladies and gentlemen, welcome back to our 40th patient event. Now, if you haven't managed to join us this morning, this is all going to be pre-recorded. So you'll be able to go to our website, kidney.org.uk, on Tuesday and watch the whole event or the individual speakers. So we'll let you know via social media as well. So our next speaker is Andrew Cole. Now, this is a man who doesn't need much of an introduction, as most of us know him as an ex-England footballer. But do we know him as a kidney patient? Let's hear more.
My name is Nina Nana, and I'm the arts editor of ITV News. And today I'm here to talk to Andrew Cole, who is an ambassador for Kidney Research UK and, of course, is a former professional footballer and one of the most successful strikers of all time. And we're going to be talking to Andrew about his experience of kidney disease, transplant, and life after transplant. So why am I doing this? Well, I know all too well the impact that kidney disease had. Almost exactly 3 years ago, October the 11th, 2018, the date is seared into my brain, my husband Steve underwent his second kidney transplant. His first was as a young man in 1986 in New Zealand. And the emotional, physical, practical toll that kidney disease and transplant and living with transplant, to mention dialysis, has really difficult to explain unless you're living through it, but it cannot be underestimated. It does take a massive toll, and it continues to do so. So, first of all, a very, very big thank you to all of you who are raising awareness of kidney disease, and the fantastic charity that continue to support patients and fund research to end kidney disease. Ultimately, ending kidney disease is really the only cure. So pleased to see you again, Andrew. You and I last talked at the beginning of lockdown, I think it was. We did a piece for News at 10, and we were doing something about people who are extremely vulnerable, and that's people like myself, like my husband, solid organ transplant recipients. How you were coping in lockdown. It's been hard for all of us, but particularly people like you and many others who really, really have had to shield. And we were just talking about the emotional impact of that. And Andrew, here we are at the other end. How are you doing?
Yeah, I'm not so bad. I'm persevering as you do. Like you said, I'm like everybody else. I'm just getting on with things the best I know how to. I think the first lockdown wasn't too bad. I've got to be honest, it wasn't too bad. I think it was the second one. The second one really started to mess with me a little bit due to the fact that I'd gone that long period on the first one and done really well, but not being able to get out on the second one was really, really tough. Mentally, it was really, really hard on me.
Yeah, well, I can completely understand that. And sometimes it felt like people like yourself, like my husband, who were shielding, I mean, really shielding, felt a little bit like they were forgotten. I mean, I don't know whether you felt a bit like that, because, that second one that came round, it was, okay, here we go again. I have to say, Andrew, the other night I was watching TV and there was a documentary on. I stumbled across a documentary, and it was all about Manchester United at the latter end of the 90s, of 1999, when Rupert Murdoch was trying to buy Manchester United. Completely forgot about that. And it was talking about why that team was so golden, was such an amazing asset. And it was showing us the stars and the goals. And you, of course, you were all over it. There were golden goals. I mean, my God, you were absolutely incredible. Do you ever watch that sort of stuff again?
No. The crazy thing is, I don't watch myself in the old games. I don't watch my interviews. I don't do anything like that. I'm the kind of individual, once I do it, I just try and move on. I get a lot of stick from my mates because, I think for me to embrace stuff like what I've achieved and all the adulation, I find it difficult because I'm just a normal person like everybody else. And so, like I said, my mates do tell me I need to embrace it a lot more. I've achieved a lot and I've brought a lot of joy to a lot of people. But like I keep saying, I'm just a normal person, I was blessed with a little bit of a talent. I just ran with it and I've been fortunate to achieve what I achieved.
Incredibly modest of you. I mean, you must stumble across images of yourself at that time. Do you recognise that person? Do you feel a connection with that person still?
Sometimes, yeah, and sometimes no. And I think when I do look at, obviously, photos and things like that, to see what I look like then to how I am now, mentally it's difficult at times. Because you're looking at yourself fit and well, and many years later, and I look at myself now, and then, that self-doubt always creeps in. I was having this conversation the other day with my consultant. That the self-doubt creeps in. You look at your body and obviously the transformation of your body from what it was to how it is now, and all those kind of things. And yeah, it does play mind games. I'm not going to sit here and lie. There's a lot of things that do play mind games now that obviously when I was fitting well, I never used to worry about. But that's part and parcel of having the illness.
You released your autobiography, fast forward towards the end of last year. I'm wondering whether the experience with your kidney disease and your transplant, did that somehow inspire you to get that book done? Because suddenly you were never known, Andrew, for being a very talkative and media hungry football player. You just got on with the football, didn't you? But since you had your kidney disease and your transplant, you somehow found yourself on a public forum talking about your experiences. Did that really inspire you to get that autobiography done? Because you suddenly thought, I've gone this far, let's talk about the whole thing.
I'll be very honest, it was my mate. He just said to me, you fancy doing another book? And I never had it in my mind. I'm tired, I was more than happy being retired, I just want to get on with things. And when he said it, I said to him, go on then. And then within, I know, a couple of months, you know, I spoke to someone, he spoke to someone, and all of a sudden I was doing a book again. So I never really thought about it. And then when I was doing the book, and naturally I was talking about things, obviously Leo, who did the book for me, did the ghostwriting for me. You know, after a couple of sessions, obviously you said leave and go home, and I sit down and think, oh my God, you're actually opening up about things you never ever spoke about before. And I was a bit worried at the time. I was worried that how people were going to perceive it, or, you know, were people looking at me as if to say, oh yeah, I'm trying to crave a little bit of limelight. And I was worried at that stage. I was thinking to myself, I don't know if I want to go through with this book, by the way, because I think I'm giving away a little bit too much information. But then, like, speaking to Leo, he was brilliant. He was absolutely brilliant, ghostwriter. And then, you know, sitting down to me, he said, no, he said, this is an unbelievable story. And actually, he said, you don't understand how good a story it is. And then we did it, and, you know, what came out after that, you know, was all positive.
I don't think anyone could ever say that you're somebody who's craved any limelight, Andrew. I think that's one of the really great things about you. I mean, the whole football generation is very different now. Let's talk about that diagnosis when you got kidney disease. Obviously, you were a super athlete. You probably still are a super athlete, amazingly physically fit. And then this thing happened to you all of a sudden. Tell us what happened.
Yeah, for me, it was so random. You know, to know that I'd gone on the trip, doing my ambassadorial role for Manchester United, coming home from the Vietnam. I felt fine. I felt not a problem. When I got home, you know, all it was, I was just gaining a little bit of water retention. I didn't really think anything of it. Lost my taste for food and things like that. And gradually, within a few days, I started putting a lot of weight. And I spoke to my old Manchester United doctor to come and have a look at me and whatever. So he popped round and said to me, look, I think you're going to have to go to the private hospital to get a checkup on that. And I did that, and then, you know, results come back. I had a mark on my kidney. So I just went into the hospital. I remember it was like a Monday morning. I went into the hospital. Yeah, it was a Monday morning. And I remember I said to my consultant at the time, I said, look, I've not got time. Yeah, I don't want to be here. I've got things to do. So he said to me, yeah, not a problem. So he walked me in, and then he said to me, have you had any symptoms? I said, no, I've got no symptoms whatsoever. So he said to me, right, what we're going to do then, we're just going to do a little biopsy, and then you can go. So I'm thinking, oh, brilliant, yeah, biopsy, because I do not like hospitals. I don't like them at all. So did the biopsy and sat me down, started talking to me, said, look, I think you've got a problem. I said, no, I need to go home. I said, I've not got time for this. Then he asked me about my symptoms and that, and I think within half an hour, regarding the symptoms, I had every symptom that he spoke about. Then they just rushed me upstairs and did what they had to do to settle me down. So when he broke it down to me in the end, he said, look, you're very, very fortunate. He said, if you wasn't as fit as you was, you know, you'd be struggling now, because basically you push your body to the limit. As you push your body to the limit, now where you're at, basically you're finished, you've collapsed. And luckily you collapsed in the right place, due to the fact that I pushed so hard, my body couldn't take it anymore. So I was in hospital. My body finally gave up when I was in the right place to give up.
Very traumatic, actually, very traumatic experience. Did you go on dialysis, Andrew?
Yeah, I was on dialysis for about 10 days. And the dialysis, I said to my mate, you know, because his mum has just passed with this disease. You know, it's for me personally, it's no life. It's very, very difficult. You run it one day, possibly for 3 hours, could be 5 hours. You know, you're very, very tired after, extremely, extremely tired after. That day's a complete write-off. And then once you're feeling okay after the day you've had it, you're back on it again. You know, so it becomes no life. It becomes frustrating. You know, constantly sleeping, and yeah, it's very, very tough. And considering what I want to do, you know, I want to still go to the gym and things like that. And, you know, to try listen to someone break that down to me, that might not be possible to the level that you want it. I couldn't quite accept it. Yeah, I know I was getting on in age and that, but I couldn't quite accept that someone is telling me I can't do the things that I want to do because I'm no longer in control of my body.
I think that's one of the things about dialysis, isn't it? My husband had 3 years of it as a teenager in New Zealand, and about 2 years this time round, and it was peritoneal, so it was 4 times a day. And we adapted it into family life. We had hooks all over the house where the fluid was hanging, and it became part of our life. We managed to go camping with it. But you're right, it's astonishing and it's effective. It's really, really difficult, and it's the mental battle, isn't it? Really, I just wonder, where do you go to? Do you have a coping mechanism?
Mine is, oh my God, my coping mechanism is not very good. It's not good. So my coping mechanism, everyone gets pushed away. Every single body gets pushed away. I don't want to talk to anybody, and I just try and break it down for myself, because I think that the difficult thing for this, if you don't understand this illness or want to try and understand it, you fight a losing battle. So you got to have people who are prepared to embrace it and try and understand it, and sit you down and have that conversation. A lot of people will look at you, you look really well, and internally you're tormenting yourself because there's certain things that you want to do or can't do, you don't feel particularly well. Or there's a day that I call it kidney day, when you can't get out of bed. If people don't understand those things, it becomes really, really difficult. So yeah, my mechanism is not the best, but it's the only way I know how to deal with it.
Did you not really speak to people?
I'll be honest with you, I remember when I had the transplant. I remember that it was just today. They give you the transplant, you in for a week or whatever, give you a medication, and then they basically say crack on from there. Yeah, you've got your appointments, but they don't offer you a service to whereby you can speak to somebody. So I do understand how people get themselves into a black hole regarding this illness. There's nothing there. I mean, there's no right, you can go and talk to someone after regarding what you're going through, how you're feeling, and that. And yeah, it becomes a bit of a dark hole, especially if you don't have people understanding it. And I found myself in that position. I was in a dark hole because my ex-partner didn't understand it, didn't understand the turmoil I'm going through mentally, not being able to do what I want to do. Or you've been a sportsman all your life, and all of a sudden that's been taken away from you. So when someone says to you, "I'll just get on with it," you got medication, you got a second chance in life. It's not as easy as that, because medication every day for the rest of your life. What kind of life is that? And that's what I said to myself when I came out, and they explained to me before the transplant, you're going to be on medication for the rest of your life. I said, no, I can't do that. I can't take tablets every day. They said, well, you're going to have to. I was trying to break that down mentally. How do you take tablets every single day for the rest of your life? But like I said, you do need understanding people around you who are prepared to understand, prepared to go through everything with you. Your up days, your bad days, the days when you're in the middle, you're not sure what you want to do. If you haven't got that mentally, you do end up tormenting yourself.
I think it's really interesting to talk about the mental impact and the mental struggles. One would imagine with you and with what you've gone through in your career that mental strength would be so deeply embedded in you. I mean, when I look at those old images of you playing, on the issue of racism and black footballers of your generation, Andrew, you were getting it left, right and centre. And the atmosphere was different. There was no support structure necessarily. It's not something we talked about. And I remember going to see football matches in the late 90s. And I, as a person of colour, I hated watching them because the language that was coming was very hurtful and scary. And I felt I had no recourse to action because it wasn't the narrative then that we abhor this and that the Prime Minister speaks up against the hideousness of racism. But you guys just had to do it and hear terrible things and not have a support structure. So in my head, I'm thinking, gosh, you must have been really mentally strong to come through that. You know, there's a new generation of black football players who are getting left, right, and centre, but we're talking about it. We're supporting them. The authorities are supporting them. You didn't have that support structure. Do you think that made you mentally stronger to cope with what's been thrown at you later on in your life?
Yeah, I believe so, because I look at it this way. My parents came to England, you know, 50s. You know, we both came from Jamaica in the 50s, and you know, as I've obviously grown up with my parents to a certain age, I understood what my dad and mum went through. You know, so my mentality was, okay, not a problem. Yeah, whatever my dad went through or my mum, I'm not going through that. You know, and that's what I made my mind about very, very early. And I'm very stubborn in that way. You know, how certain people used to speak to my mum and dad back then, I refuse to let anyone speak to me that way. So yeah, you have to build out that resilience, you know, because otherwise you will get swept under the carpet. You know, and so sometimes yeah, people might have believed us arrogant or something. No, none of that. None of that. I'm just doing that things that I wasn't prepared to let people get away with. Yeah, you can speak to my parents like that. Yeah, they have to accept it. But I refuse to accept what they went through. And I think naturally that has made me stronger throughout the years. I think regarding my illness, yeah, to a certain extent, all that kind of stuff I have carried on through. But then I actually realized that the way I used to attack those things, I couldn't attack my illness exactly the same way, because it's a totally different thing. My mindset had to change. You know, I remember when I used to continue to go to the gym and try and make out nothing was wrong, and then realize by the time I got home, I sleep for the rest of the day. You know, and then you start questioning yourself, well, this doesn't actually work. You know, and I thought it would have been a doddle for me, because mentally I'm very, very strong. But like I said, I realized what you did in football in terms mentally, this illness is a totally different agenda. You're going to have to try and approach it in a different manner.
I think when it comes to mental health and not talking about what you're going through, I mean, my husband doesn't really, you know, he's lived with it for decades. I'm wondering whether it's a man thing in particular. I mean, my husband was a surfer. You're a professional footballer. It's the taking away of that is so difficult. You can't articulate that. Do you think it's a fair comment?
Yeah, I'll be honest. You know, I don't know if it's. Look, I don't know if it's the man's pride to talk about how he feels and where. Because I think as men, you know, we have a lot of pride in, you know, where they're saying the pride before the fall, and you know, we don't like to talk about things that we believe are going to make us be perceived as weak, because that's what men do. And I looked at the time, when I was going through it all, I was just trying to break it down mentally for me. Right, how am I going to try and approach this? You know, I'm going to try and sit down and explain what I'm going through. And by the time you're asking all these questions to yourself, you actually come out with your own solution. You just say, nah, I can't talk about it, I'm a man here. You know, it's basically just man up, get on with it, because that's what we get told as men. Just man up, get on with it, move on. You know, and then you get to that stage and you actually turn around and say to yourself, I can't actually move on anymore. You know, I can't man up because I've got so many things going on inside my head that I'm gonna have to speak to someone about it. You know, and like I said, you do find yourself digging a deeper and deeper hole for yourself if you're not prepared to come out and talk about it. So I mean, when I first come out and spoke about it, what I was going through, I even had my ex-boss call me. And he said to me, Jesus, you are a brave boy, you are, by the way. And I just had to say, boss, you know, I'm at that stage in my life whereby what I'm going through and what I've gone through, you know, for me to continue to hold it, it's only going to cause me problems. You know, so long term, if I can try and help anybody else, you know, you got to get it off your chest.
Your ex-boss, is that Alex?
Yes.
That's great to have people reaching out to you, isn't it? Because there are some other footballers that have also had kidney transplants. So this can affect absolutely anyone, and it's great that Alex Ferguson reached out to you to say, to thank you, really. Thank you for talking about it.
Yeah, I look at it this way now, you know, I'm more than prepared to help anybody, any sportsman who's going through, obviously, what I've gone through. You know, I'm more than prepared to open up and have that chat with anybody, you know, because I know it come at the end of my career, tired, I was kind of like enjoying retirement, and then all of a sudden I vote from the blue and everything changes. So naturally, it's different to the guys who are still playing and they find themselves in a position that I find myself in now. But I think anyone in this position who can try and help another individual, you have to try and do it. It's and like I said, it's for me personally, what I know now, what I understand so much now, even more so after went to the games, the transplant games, and speaking to a lot of those guys as well. We all go through the same thing. Mentally, we think we can't do things, but we can. It's about support network. We've got the right support network to help us. At times, as being men, as being women, the partners have ended up getting up, leaving them because they don't want to deal with it. But we all have the same common goals. We still believe we can get there. You just need people to believe in us. And like I said, being at the transplant games and watching those guys play football, I was in tears because I'm turning around and saying to myself, I can actually do it if I want to do it. Because these guys are showing me. And they're telling me how proud they are of me. I'm like saying, no, you guys are giving me more inspiration than that. I can do what I want to do, still in the position I find myself in.
You've settled into your regime of taking the drugs that you have to take. There's a lot of drugs, isn't it? The anti-rejection drugs. Do you still get good days and bad days? Are there more good days than bad days?
Oh, 100%. I think there's more good days as your body starts to get used to it. The bad days, for me, because I live by myself now, I've still got to get up and do things even if I don't want to do them. It's not as if I can rely on anybody. So the bad days, I have to accept, okay, yeah, I usually get up early in the morning. You might have to have a couple more hours in bed just relaxing or whatever. And then you've got to move on from there. But it's as I say to everyone now, it's not easy to deal with. Not easy, but it depends how you want to try and deal with it. And I've had a lot of good people around me, people that I thought I wasn't too sure about. And the way they've stood up has been absolutely phenomenal. I've never known so many people prepared to put themselves out for me and do the things that I needed doing.
Of course, it was your nephew that donated his kidney. I think the really important thing, and you and I have talked about this before, is that transplants are amazing. They are incredible, aren't they, in terms of restoring life to you? But ultimately, they are not the answer.
Yeah.
The answer is not to have kidney disease in the first place.
150%. A transplant is not the answer, but like I said before, and people think, oh, you've got a transplant, that's the answer, you can live as per normal. And when you try and break it down, they don't understand. It's not the cure. It gives you a lifespan of possibly, depending how well the kidney works, 10, 15, 20 years. I was having this conversation the other day. I said it was like growing up when I was younger. People used to start a car with a choke. If the choke decides it doesn't want to work, that means the car's not going to work. And that's what it is with the kidney. If you wake up one morning and the kidney says, I don't fancy it today, we're back to square one. And I think in the back of my mind, that's what I always worry about, like waking up in the morning, and if it fancies it today and if it doesn't fancy it today, I'm more than happy when it fancies it. But in the back of my mind, I'm saying to myself, well, if I wake up one morning and the kidney says, I don't really fancy it today, I'm back to square one. So mentally, I'm half tormenting myself thinking, I'm not sure if I can go back to square one again because this is hard work and it's hard on people who don't understand, but mentally it's hard on the individual.
It's estimated around 3 million people in the UK have kidney disease, and many of them won't know that they've got kidney disease. Kidney Research UK says incidences of kidney disease are rising, and that's probably to do with rates of diabetes, obesity. It's not very sexy to talk about kidney health, is it really? But, those of us that live in an environment or a family situation where you do have to talk about kidney health, you cannot overemphasize how important it is to tell people to look after your kidneys.
It's very important because it's not for me personally, it's not a glamour organ. People look at it, what does it do? Well, it's basically your toilet for your body. That's what it does. So it does a hell of a lot of work. Yeah, but it's not like your heart, is it? Whoa. What do you mean it's not like your heart? You know, your kidney moves all the toxins around your body, you know, it makes sure everything's level and things like that. So yeah, people don't look at it, and it doesn't get as much appreciation as heart and things like that. But like I said, as I've got older, and especially working with this illness, I understand it a hell of a lot more. So as I break it down to people, they start to understand, oh, okay, it's an important organ. Well, every organ in your body is important because every organ does something, you know, but this is one of the most important organs in your body.
Tell us about the setting up of the Andy Cole Fund, because one of the most interesting things about this is mental health well-being is right at the top of the list of what your charity is aiming to do.
Yeah, I think for me to being able to set that fund up with kidney research, you know, then given the opportunity to do it. When I sat down and spoke to them, I had to mention mental health because I don't think people understand what you actually go through. So I touched on it previously. When you have your transplant, you know, you're in for a week, they give you a medication, they give you appointments, and they say, okay, then there you go, thank you very much, move on. You're thinking, oh yeah, I feel a lot better now. I can do the things to a certain extent I want to do. Then when things start to get on top, there's not a facility whereby you can actually say to them, well, I need to talk to somebody. No, I found that, you know, when I had my transplant, brilliant, come out after a week, and I thought, oh, yeah, fantastic. And then I realized I couldn't talk to anybody. You know, like I said, I couldn't talk to my ex-partner. I'll get on with it. You've been given a second chance. You got your medication. It's like, well, it's more than second chance. It's more than medication. You know, it's about mental well-being here. I actually need to get things off my chest. But if someone's not susceptible to hearing that, you bottle everything up. So why I wanted to do it and why I mentioned mental health is I want people to understand having a kidney transplant is not a cure. You're going to have issues. You're going to find yourself in dark places. You know, you're going to find yourself thinking about things that you've never thought about before. But we should have the opportunity to be able to get it off our chest, you know, speak to people who understand what you're going through. And that's why I want to do. I want people to understand that, you know, when you think exterior looks really good, oh, you look so good. Interior doesn't work at times. That's what people need to understand.
Tell us where you're at now, Andrew. What does today hold for you? Future projects, perhaps still involved in the football world?
For me, I just try and take over. The last month has been really tough because I went down with COVID. I had COVID really bad. You know, it's one of those touch and go situations again. I'm like, oh my gosh, man! In 6-7 years, I've been there twice. So I just try and get on with things the best I know how. Yeah, there's good days, there's bad days, but like I said, I surround myself with a lot of positivity. Surround myself with real good people now, who are prepared to go out their way to make me better, make me feel better, to make me feel like you don't need to question yourself anymore. You need to talk about it. You need to come and talk to us. And I feel so comfortable in that. Yeah, there's days that I'm not gonna lie. Yeah, I do question myself. I want to do things. I want to do things that I want to do before, and sometimes I push my body to the limit, and I find out the day after that wasn't the thing to do. But that's me, and I know no better. And when people say, "No, relax, chill out," I can't do that. My parents didn't bring me out like that. I watched them work extremely hard before I left home when I was 40. So I can't rest on my laurels now or think about, just chill out. No, I'm built differently.
Well, thankfully for so many people, you're built differently. You said you surround yourself with positive. You're now surrounding people with your words who also have kidney disease or are waiting to have a transplant or on dialysis. It's really incredibly important that you talk about this and that you speak openly about this, because it makes a massive difference. I really do know it makes a massive difference. And your impact through your fund is enormous. So continue to be you and continue to think that you could do absolutely everything, because you're Andrew Cole. I'm pretty sure you can. Thank you for being so honest with us about the difficulties and the mountain that you climb, and encouraging other people just to have a go at climbing that mountain. But to make sure we look after ourselves now, because the world of kidney transplant is astonishing, but we can be one step ahead of it by looking after our kidneys. And I think you talking about it is absolutely amazing. Raising awareness of it is incredibly powerful. So thank you so much indeed, Andrew, for joining us. And thanks for the session with Andy Cole Fund, which is providing support, particularly on the mental health, the mental wellbeing side. Now, if anyone wants to find out more or support the Andy Cole Fund, please visit the Kidney Research UK website, where you will find a dedicated page. Thank you everyone for joining us today. I really hope you found that incredibly informative and helpful. It's always brilliant to talk to you, Andrew.
Thank you.
And to see that you are, goodness me, you're fighting the fight. So thank you for that.
Thank you very much.
Thank you.
Andrew Cole, well, very interesting and great to hear an insight into his world. So our final speaker today is Nicola Ward, Head of Nursing at Renal Services. Now, Nicola has been a renal nurse since 1993, where she was working at the Royal Free Hospital in London. She's now Head of Nursing at Renal Services, and we're going to hear about the challenges of COVID, and what a challenge, and dialysis.
Hi, thank you very much, Pete. So my name is Nicola Ward. As Peter said, I'm Head of Nursing for Renal Services, and I just wanted to talk to you about COVID-19 and the impact it's had on dialysis. So the agenda today is risks, home therapy versus in-centre dialysis, the psychological impact on COVID-19, and the enhanced measures and their impact that we've had on renal services, and what's next. What does the future hold for us? So in the initial days, the main concern was the relative ease of catching COVID. All dialysis patients are at increased risk of becoming severely unwell once they get COVID, mainly due to the multiple comorbid conditions that they have, either as a cause of or a consequence of the condition, e.g. diabetes. Thankfully, the risk of catching it has much reduced following enhanced infection prevention precautions and the vaccination programme. How effective the vaccines are in dialysis patients is yet to be determined, but as we all know now that the third doses are being offered, and we'll discuss this a little bit later on. So looking at the risks associated with COVID for the dialysis patients, of all the comorbidities, chronic renal failure, so those not on dialysis or transplanted, were found to be at the greater risk of being severely unwell and at a higher mortality rate. The main reason for this being patients with chronic renal failure have a defective immune system. Of course, all patients with a chronic disease are at greater risk than that of the general population, but obviously our main focus is those with renal failure. When we consider home therapies versus in-centre dialysis, those receiving home dialysis have a lower risk of catching COVID than those travelling to units to receive their dialysis. We're familiar with words like lockdown, social distancing and shielding these days, and they're an impossibility for our outpatient population. They usually have to travel at least three times a week to receive their treatment, and this involves having contact with other patients and staff as a result of this. Also, if a patient or a member of staff became positive in the dialysis unit, it's often brought into the unit with a high risk of spreading to all. Obviously, patients that are positive don't have a choice but to come to dialysis or transfer to their main unit. Looking at the psychosocial impact of COVID-19, studies have shown that the psychosocial impact of COVID-19 on patients receiving dialysis are known to be more moderately worried about the effect of their mental health. We talked about shielding and social distancing earlier and how difficult this is for dialysis patients. Life at the dialysis centre is not set up for social distancing or shielding. You're told to shield, but still come for dialysis 3 times a week. So looking further into the impact of COVID-19, obviously it starts with the journey. Waiting rooms where social distancing is challenging. Even if chairs are spaced 2 metres apart, are there enough chairs? Do patients have to stand up? Is there room in the waiting room for the chairs to be 2 metres apart? Just going back to the journey, you often have to travel with other passengers. You're in very close proximity. The other thing is that maybe you're not travelling with others and it's just a single patient journey. And has that impacted on your dialysis time and how long it takes for you to come into the unit? We've talked about the waiting room chairs, but also the same applies to the dialysis chairs in the actual unit. It's okay in the larger clinics, but those in the smaller clinics where the dialysis chairs are closer together, are they 2 metres apart? The very nature of dialysis itself, the close contact for connection, disconnection, vital signs monitoring, it often involves contact with multiple staff who've cared for multiple patients. Considerations also for those patients that work and if they have a requirement to isolate, if there is contact with them with a positive patient in the unit and the impact that has on their working life, but also consideration for family life. You don't have to work for the need to isolate to affect your home life. All the above can lead to psychological distress, which may result in worsening of or development of anxiety, depression or poor sleep. The concerns related around COVID-19 can also be the cause of patients missing treatment, which in effect increases the risk of hospitalisation or mortality. On a more positive note, those who live alone and have been isolating from family and friends have seen their regular visits to dialysis as their only chance to socialise or see other people. So some do find it positive. It's not all negative. So we've already talked about transport and the close proximity with other patients, and we're talking about the enhanced measures here. Self-drivers can often feel isolated if they're asked to wait outside in their cars before coming into the dialysis unit. It can increase anxiety about being forgotten or will be the last to be connected. We have triage, which seems to have been introduced in every dialysis clinic. Sometimes it's done in the transport, or sometimes it's done at the entry to the clinic, or both. Sometimes you can feel a bit over-triaged. You're asked the same questions every time. You have a fear that what if you need to say yes to one of these questions, or what if your temperature is high? In my experience, I've had patients not disclosing that a family member is positive due to their fear of being turned away from dialysis. And in the past, that's meant sort of having to isolate whole bays of patients because we weren't given the correct information. Social distance we've talked about. Some used to treat their dialysis sessions as a social occasion, built up very good relationships with fellow patients. They're no longer able to freely walk around and reduce interaction with others. We've also had to take things away from waiting rooms. Patient leaflets, for example, these should still be available, but you have to ask, they're not freely available to pick up. Of course, we have the enhanced PPE for staff, in particular the mask wearing at all times. We're familiar with staff wearing visors for connection and disconnection procedures, but the addition of masks makes communication even harder for some, those hard of hearing in particular, not to mention the full respiratory PPE gowns, etc. that you have to wear for positives. Obviously, it's not just the staff that have to wear masks, it's the patients as well. And the same reduces communication. They may feel uncomfortable, and patients with respiratory conditions in particular find difficulty tolerating this. There's a fear associated with this of staff not wanting to care for patients not wearing masks. Some units in the height of the pandemic decided to reduce dialysis hours. And this was under the instruction of the trusts, and obviously this could have led to anxiety of the effect of the condition, dialysis adequacy, and we had the reduction of the frequency of dialysis. Some patients went from 3 times a week to twice a week. The enhanced cleaning measures often cause delays, the next shift not being able to enter the area until the previous shift has left and all the cleaning complete, which obviously left to delays. Some trusts introduce one-way systems. Our units are not particularly designed for this. The areas used as waiting rooms, which are not designed for. We have fire exits used as temporary exits to make way for the one-way system, and with that comes the increased risk of falls. We have toilet facilities mainly in the waiting areas and not in the clinical areas. So patients at the end of dialysis often had to go against the one-way system to use the toilet back in the waiting room, which meant they're entering a waiting room full of patients from another shift. The routine swabbing, lots of the clinics do routine swabbing each week. Some do more than once a week. Obviously, this is very good practice and lots of positives have been identified with routine swabbing, but it's not a pleasant experience. And I know for one, I would not want to be having the swab each week. We then have the contact swabbing of being swabbed after each contact and the anxiety this leads to. Some will only have it if a shared transport with a positive patient or if they're on the same shift or in the same waiting room, but some do the whole shift. So it's very different in each trust. We also have the transfer of symptomatic or positive patients to the main trust. Some of the satellite units don't actually dialyse the positive patients or don't have isolation rooms or the facilities to do so. And then we have the anxiety of having to do that and being transferred. And it may be a different shift, maybe a longer journey, unfamiliar surroundings and unfamiliar staff. Unable to swap shifts, this became more difficult with the aim of bubbling shifts. Appointments to attend, etc., were very difficult when patients were asking to swap shifts, and we were unable to accommodate this. In some trusts, the curtains were pulled between the dialysis stations. Patients report increased isolation, and staff report reduced visibility of patients and reduces the monitoring ability and increases the risk. Some patients and some staff do like this though. In the height of pandemic and maybe continued, refreshments were put on hold. And as I said, this is the case, still the case in some clinics, or they were served to alternate patients, or patients were just encouraged to bring their own. Visitors and carers not being allowed into clinics, and the anxiety and distress that this causes to our patients. We then have the impact of the staff sickness and the isolation requirements, leading to possible short staff, additional stress to nursing staff, leading to low morale, and the possible impact of care to patients. And then not forgetting our home therapy patients with deliveries possibly left at the door and delivery drivers not being able to enter patients' homes. So moving on, what's next? So we now know about the third vaccine, which is being offered to our patients. So the UK Kidney Association has reviewed the Joint Committee on Vaccination and Immunisation guideline and is recommending the use of a third primary COVID vaccine in the following kidney patients. So those who have had a transplant, those on the transplant waiting list, all patients on dialysis, and patients who at the time of the original second vaccine were receiving significant immunosuppression. The third primary COVID dose will rely on renal units to identify those who are eligible, and it will give patients access to the third primary dose as quickly as possible. This will be arranged either by your hospital hub or via the GP. And then moving forward, what's next? Lots of the enhanced measures remain in place. We haven't changed much at all. In some ways, it doesn't seem so bad. Perhaps we've learned to live with these things now. Moving forward with the layout of new units, consider one-way systems and how we would social distance and location of toilets, etc. We'll wait and see. Consideration of other things that maybe weren't so relevant last year. Now the country is out of lockdown. Will flu have a bigger impact, or norovirus? I haven't told you anything today that you didn't already know. I just wanted to show that we do have an awareness of the impacts to patients on COVID and its associated precautions. The aim of everything put into place is to keep you as safe as possible, but we know the possible negative impact, particularly on mental health, that these things may cause. Thank you very much for listening to me.
Nicola Ward, Head of Nursing Services, and thank you very much for that insight into your world and a lot of people's world at the moment. So that ends the conference or the patient event for this year. I'm going to hand you over to Jim Higgins who's going to close the event.
Hi everyone. Thank you all for attending, and I must say it's a very, very informative event for us. The transplant and research and pharmacy updates were really, really informative. I do say personally I prefer the face-to-face meetings, perhaps for next year. So thank you all for attending today. Thank you all to the speakers especially. They make a day perfect. And I hope to speak to you all and see you all again next year. Thank you very much.